Good morning. We had a very successful session yesterday under the aegis of National Diabetes, Obesity and Cholesterol Foundation and Port Cedar Hospital for Diabetes and Life Sciences. Our Ahuja Bajaj Symposium 6 first part was conducted yesterday. And we had tremendous response on this, and I'll show you some. But before that, just to recap, these two gentlemen, Professor Ahuja and Professor Bajaj, very distinguished gentlemen, both professors of medicine and endocrinology at All India Institute of Medical Sciences, and under them, many of us were trained. Dr. Ahuja was first to start Research Society of the Study of Diabetes in India, which is now the prime research society for diabetes in this part of the world. And Professor Bajaj, much decorated, highly celebrated doctor, was first to get International Diabetes Federation Congress in 1977 to New Delhi. Yesterday, we had 740 people logged in till 10 p.m. in the night. A highly interactive session, much appreciated. Many people from outside, USA, UK, they spoke on the various topics of current relevance. Today we have very interesting session. 12 lectures, including 5 nutrition-related lectures and 4 international speakers. I'm sure, and I can assure you, I'm very confident that this is going to be very interesting and informative session. Before I begin my lecture, once again, those who want to get a book written by me, this is a comprehensive book, good for beginners and good for nutritionists, good for anybody in the working in this area, wants to get more knowledge in this area. Please email to koeldattac@gmail.com and we'll courier you a free copy. But your email must come and you should have attended the session. Now I'll come to my topic. And this is concerning the combination therapy with DPP-4 inhibitors and SGLT2 inhibitors, which is a current concept in the treatment of diabetes. This is my disclosure. Now, before I begin, this concept must be very clear to you. Clear to anybody who's working in this area, who's treating diabetic patients. Early aggressive treatment and combination therapy at the various pathophysiological facets of diabetes makes sense now. And I'll show you a couple of slides to clarify this concept. Now, there's a guideline approach and there is a pathophysiological approach. Now, guideline approach is what we have been taught in the MBBS earlier and continue to be propagated by many people. This is a sort of an easygoing approach. One by one, you add one tablet today, wait for 3-4 months, and then add another one or escalate the dose, and then many years go by before you start insulin therapy. Versus pathophysiological approach. Now, pathophysiology has has been augmented by so many research studies that it is no more the same pathophysiology that we learned in the MBBS years. And if we go by pathophysiological approach, then we should get combination therapy. Now, this is very well shown here. Now, if we use the usual guideline approach, we go slow and slow, diet and exercise, one monotherapy after titration, the second tablet, and then insulin and so on. And versus upfront, if we hit it hard, a reappropriation of therapy, a combination therapy, then hemoglobin A1C stays down versus the guideline approach where it goes up and down and up and down. Now, here are the pathological facets for diabetes as we know now. Uh, it concerns pancreas, of course, but gut also, the adipose tissue, kidney, muscle, brain, liver, islet cells, every, number of pathological facets are there, while we knew only pancreas 20 years back. Now, DPP4 inhibitors act on several facets, and I'm not going to details of that, but if we combine these DPP4 inhibitors with SGLT2 inhibitors, then we are hitting at almost all facets of pathophysiology. So, initial aggressive therapy. Now, this is a poorly managed glycemia. Maybe these people are managing with a guideline approach here, and this is aggressively managed hyperglycemia. And if you look at that, that initial cost is incremental in aggressively managed. It is common sense because we are using multiple drugs here versus poorly managed where we are going one by one. But look at the initiation of diabetes complications. In aggressively managed, initiation takes a long time and many complications may not develop, while in poorly managed, they rise pretty fast and ultimately patient has decreased life expectancy, reduced quality of life, and patient is a loser as far as the finances are also concerned because huge financial implications if patient develop complications. So finally, if you see over the years, it makes sense that we use aggressive treatment of glycemia. Now there is some proof of this concept. Look at this study in DB mice. And this is concerning foam cells, not blood sugar, but the atherosclerosis. Foam cell formation, if you see, if we give nothing, then foam cell formation is high. Ipragliflozin, SGLT2 inhibitor, then it decreases. Allogliptin also it decreases somewhat, and combination therapy it decreases further. And this is very well illustrated in the next diagram. So if you see that the control, this is the artery, and you see the atherosclerosis here, ipragliflozin here, decrease in atherosclerosis, allogliptin, some decrease in atherosclerosis, and combination therapy, arteries are clean. So the combination of SGLT2 inhibitor and DPP4 inhibitors are working well as far as atherosclerosis as well. See this very clearly if you compare the two. Now there's some pertinent Indian data as far as these two drugs are concerned. First, we are concerned about glucagon. Now, glucagon is targeted by DPP4 inhibitors. And in this experiment, which we published some time back, we compared newly diagnosed patients with diabetes and non-diabetic control, both were non-obese, and compared their fasting glucagon levels. And you can see, even in newly diagnosed patients, the fasting glucagon levels are very high. So this must be targeted. And they are not going to be targeted alone if we use SGLT2 inhibitors, because you must be knowing by now that SGLT2 inhibitors increase glucagon. The second thing is the levels of DPP in the blood, circulating DPP. Now, using the same experiment, non-obese diabetes patients newly diagnosed versus control, the DPP4 levels in the blood are high. Now, DPP4 itself is pathogenic, causes insulin resistance, new onset diabetes, inflammation, but particularly detrimental to liver, apoptosis and fibrosis of the liver, and increased advanced glycosylation end product. So we have seen two things in Indian patients. This we published in BMJ. Two things in Indian patients. Number one, the glucagon levels may be high in newly diagnosed patients with diabetes, and they must be countered. And the second thing is circulating DPP4, which is pathogenic, is high. So if we combine the two, what happens? Look at this. DPP4 decrease glucagon while SGLT2 inhibitors increase glucagon. So DPP4 inhibitors are countering some effect of glucagon. DPP4 inhibitors increase insulin, SGLT2 inhibitor decrease insulin. And similarly, increased endogenous glucose production by SGLT2 inhibitor is decreased by DPP4. So compensatory mechanism, theoretically, this is going to do better than either of them alone. Now let's look at some other clinical data. And that data has come from Defronzo's group. Now if you look at this slide, this has 5 groups. These 2 groups are combination therapy. 25 milligram of empagliflozin, 5 milligram of linagliptin here, black bar, 10 milligram of empagliflozin, 5 milligram of linagliptin here, and then empagliflozin alone 25, then 10, and linagliptin last one. And with the baseline hemoglobin A1C of 7 or 8, as a second line therapy, this combination worked very well. And you see, decrease in hemoglobin A1C by 1.19%, approximately that, which is a huge improvement if we are using this combination as a second line therapy. But if baseline hemoglobin A1C is more than 8.5, now look at this, more than 8.5, averaging 9, then this decrease in A1C by this combination is huge, 1.84% and 1.61%. So remarkable decrease in hemoglobin A1C when the baseline hemoglobin A1C level is high. Now remember, about 60 to 70% of patients of diabetes in India are uncontrolled, and about 30 to 40% will have baseline hemoglobin A1C more than 8.5 or even 9%, where this combination should work very well. Now, if we look at the fasting blood glucose, similar to hemoglobin A1C, there is a good reduction of fasting blood glucose by 35 or 32 milligram percent with this combination of empagliflozin and linagliptin. And over 24 weeks, 60% of the patients achieved hemoglobin A1C, target hemoglobin A1C of less than 7%. So this is working very well. It is working fast. And over 24 weeks, it is solving problems of about 2/3 of the patients, problem being uncontrolled hemoglobin A1C. So if we look at these 2 seminal studies, both from Defronzo's group, Levine et al., when it is used as first-line therapy, this combination, and Defronzo, this combination is used as second-line therapy, depending on hemoglobin A1C is less than 8.5 or more than 8.5, huge reduction of hemoglobin A1C with this combination. Look at the Levine study. More than 8.5, 1.92% reduction in hemoglobin A1C. And this I have already, Defronzo's study I have already told. But another thing that we often want, if patient is given a drug and there is a good reduction of hemoglobin A1C, then patient remains at that hemoglobin A1C for some period of time. We don't want the drug to fail. We don't want hemoglobin A1C to go up and down like in that guideline approach and remain at a level. And this is what this drug is doing, at least up to, this combination is doing at least up to 52 weeks. Look at this. Within a short period of time, 6 weeks, many of the patients will achieve hemoglobin A1C, so fast reduction, and then by 12 weeks further, and then there is a straight line. Means those who have achieved have remained at the same level up to 52 weeks. meaning thereby it is not failing up to 52 weeks. Of course, we have to see further study to see whether it is failing any further. So this is good. This is what we want. Now, as far as effect of body weight and blood pressure is concerned, this is predominantly due to SGLT2 inhibitors. And if you look at this, that whether you're using combination of linagliptin or empagliflozin, these two are combinations, or SGLT2 alone, the sustained and comparable reduction in body weight occurs versus only on linagliptin. So this is very well known, and SGLT2 inhibitors are responsible for weight loss. And similarly, if you look at the systolic and the diastolic blood pressure, any combination with the SGLT2 inhibitor or SGLT2 inhibitor alone will lower blood pressure by 2 to 3 millimeters mercury. But one added advantage is, and this is what we often see in many of our patients, high uric acid, linagliptin is known to suppress xanthine oxidase inhibitor oxidase activity, and so it may lower uric acid. And if you look at the empagliflozin in 10 and 25 milligram doses, it further lowers the uric acid. So both are good for uric acid. But most importantly, we are doubly reassured about cardiovascular and renal safety. We all know about EMPA-REG trial, how cardiovascular mortality, all-cause death, etc., all are remarkably reduced with empagliflozin. And we are reassured about linagliptin by Carmelina trial as compared to the placebo. The cardiovascular endpoints were similar and they're not worse off. So one is doing so good as far as cardiovascular endpoints is concerned, the other is neutral, and so this combination is good to go as far as the cardiovascular disease patients are concerned. And similarly, as far as renal benefits are concerned, you look at the EMPA-REG outcome trial, there's a 39% reduction in incident of worsening in nephropathy, so it is good, doing good to the kidney. And in Carmelina trial, the composite endpoint of time to death due to kidney disease progression to end-stage renal disease and sustained eGFR decrease by 40% is not worsened with linagliptin, demonstrating a reassured long-term safety profile. And in fact, it may decrease albuminuria and UACR worsening. So one is doing good as far as nephropathy is concerned, other is also doing good as far as nephropathy is concerned. So two big issues about heart and kidney, both are addressed very well with this combination. Now, I'm not going to detail because of shortage of time about the various mechanisms. There are a number of mechanisms through which the SGLT2 and DP4 may act as far as heart is concerned. But I'll show you some interesting, very interesting picture about how SGLT2 inhibitor empagliflozin is acting on the cardiac fibrosis. Now, this is the photograph from the EMPA-REG outcome trial, subsequent paper. And look at this. The no empagliflozin has been given, and this is the cardiomyocyte, myofibroblast with marked fibrosis. You see this tendrils marked fibrosis. And after empagliflozin, look at this. Marked decrease in the fibrosis, remodel cardiac myofibroblast. This is remarkable. In our MBBS and MD years, we never thought that a fibrosis can be reversed. So this is reversing fibrosis, and a clinical correlate of that is that it is decreasing left ventricular mass. Look at this, decrease in the left ventricular mass in the empagliflozin. So cardiac remodeling is occurring. Another issue is hypoglycemia and genital infection. And in this comparative data, SGLT2 and DP4, when given even one tablet versus sequentially, there was numerical decrease in the hypoglycemia UTI, but substantial decrease in significant decrease in genital mycotic infection, which is also shown in multiple studies that if we give this combination versus if we give these two drugs separately or SGLT2 alone, then this drug actually decreases the genital mycotic infection because of inhibition of DP24 enzyme present in some bacteria fungi. So, where should we give these combination? Patients with diabetes who are unable to control, have adequate glycemic control with metformin therapy, patients who cannot use metformin, patients who have a high baseline A1C. So this is my final slide. This combination addresses multiple pathophysiological defects and is a part of aggressive therapy, and that's what we should use now. High efficacy of this combination providing significant reduction in hemoglobin A1C across baseline, early achievement of glycemic goal with durable efficacy, weight reduction, blood pressure reduction, cardio-renal protection is the top icing on the cake, and linagliptin and empagliflozin both have proven renal safety and possible renal benefit. Uh, Potential of lower genital tract infection and genital mycotic infection with this fixed dose combination, and of course, compliance is better with the once daily pill. So thank you again for joining in, and we have many more interesting lectures subsequently. And at this point of time, I will hand over mic to Dr. Atul Luthra, my colleague, who's a director of Fortis CDOC Center for Diabetes in Fortis, Gurgaon, and he will take over and introduce the next speaker. Atul, are you there?
Yes, sir.
Okay, please take.
My video is not starting, so I can do it audio.
Yeah, you can do it with audio.
I can do it audio alone. Okay, so yes, now I can start my video. Thank you, sir. And it is my privilege to invite for the next lecture Dr. Sandeep Tak, who's a senior consultant with interest in diabetology. He's the professor, Department of Internal Medicine at SN Medical College, Jodhpur, Rajasthan. And he will be talking about drugs causing diabetes, especially focusing on newer drugs. Dr. Sandeep Tak, please.
Thank you, sir. Thank you, Dr. Luthra, sir, for kind introduction. And at the outset, I would like to thank Dr. Anup Mishra, sir, my teacher, Dr. Jitesh Gupta, and organizing committee for this invitation at this esteemed platform. My topic is drugs causing diabetes and focus on the newer drugs. Several drugs may cause diabetes or worsen glycemic control in a pre-existing diabetes. That's why drug-induced diabetes is identified as a separate etiological category by the WHO and ADA. Drugs may cause alteration in the glucose metabolism by inducing the insulin resistance, inhibition of the insulin secretion, beta cell dysfunction or destruction, or direct effect on the glucose metabolism. These potential diabetogenic drugs may cause development.
I'm sorry to interrupt. Have you shared your slide?
Can't you see it?
No, sir, I'm not. It's not visible.
You can share your screen.
It is there, I think.
The green bar will show a share screen.
It's there?
Yes, sir. So could you go back to the first slide?
Yeah. So my topic is drug-induced diabetes with the focus on the newer drugs. Drugs may cause alteration in the glucose metabolism by either inducing insulin resistance, inhibition of the insulin secretion, beta cell dysfunction or destruction, or effect on the glucose metabolism. These potential diabetogenic drugs may cause development of the transient hyperglycemia or a diabetes. Drug-induced diabetes may be very slow to develop and can be missed, or may be very abrupt onset with the presentation as a diabetic ketoacidosis. Awareness about the potential hyperglycemic effect of the drugs is therefore helpful in anticipating deterioration in the glycemic control in the pre-existing diabetics or in an early detection of diabetes by screening of the high-risk patients on such drugs. And early detection of the diabetes induced by certain drugs like CNI inhibitors, PI3K inhibitors has a potential to be reversed if culprit drug is stopped early. Exact figures are not known about the drug-induced diabetes. However, currently, when the polypharmacy is norm rather than the exception, significant number of the patients' development of the diabetes may at least partly be contributed by the drugs. Increasing use of atypical antipsychotics, newer anti-cancer drugs, immunosuppressants has also increased the risk of drug-induced diabetes. These are the possible mechanisms by drugs can induce diabetes. We will be coming to them one by one. Newer drugs like PI3K inhibitors have a direct effect on the glucose metabolism, irrespective of the insulin resistance or insulin secretion, and they have a direct effect on the glucose metabolism. Coming to the most important drugs like the anti-cancer drugs, immune checkpoint inhibitors. These are the newer drugs which has a targeted therapy and that they drastically change the management of the cancer and has improved the survival. They are usually used in the treatment of the malignant melanoma, lymphoma, or renal and lung cancers. Currently, there are three major types of the CPIs that are in clinical use. That includes the PD-1 inhibitors, PD-L1 inhibitors, and anti-CL4 antibodies. CPI is associated with the autoimmune complications and often involve the endocrine tissues. Thyroiditis, adrenalitis, and autoimmune diabetes are the important complications. Endocrine side effects are unique, means that they are rarely reversible and does not respond to steroids. Although CPI diabetes is rare, 1 to 2%, but because it's irreversible, it has a very significant morbidity. CPI-DM is characterized by acute onset of hyperglycemia with severe insulin deficiency. Diabetic ketoacidosis or hyperglycemia, severe hyperglycemia is a common initial presentation. CPI-DM can occur with the pre-existing type 2 diabetes also, and differentiating feature would be presence of the autoantibodies. Onset of the CPI-DM after initiation of CPI-M is highly variable, but median time of diagnosis is 7 to 17 weeks. Surprisingly, CPI-DM onset may indicate improved tumor response. Only 49% of the CPI-DM patients have any islet autoantibodies, and most common is anti-GAD65. And 3/4 of the CPI-DM cases are associated with the PD-1 inhibitor use. The effect of the PD-1 therapy on the T-cell regulatory function is thought to play an important role in development of the autoimmune diabetes. And majority of patients have other risk factor, genetic susceptibility to type 1 diabetes like the HLA-DR4 allele. There are also few case reports of diabetes due to CPI-associated generalized lipodystrophy and severe insulin resistance rather than insulin deficiency. This is the schematic representation that suggests what are the mechanisms. Another important drug, newer drug that was launched in 2019, approved by the FDA for the management of the advanced metastatic breast cancer, that is a PI3K inhibitor, alpelisib. Patients being treated with alpelisib have experienced severe hyperglycemia, and safety of alpelisib in those with type 1 diabetes or uncontrolled type 2 diabetes is not known. FDA advises healthcare professionals to obtain fasting glucose and HbA1c level prior to optimizing glycemic control. The most common adverse effects with alpelisib is hyperglycemia. Almost 64% of the patients experience hyperglycemia, and if the patient is pre-diabetic, 74% patients develop hyperglycemia. Hyperglycemia typically appears within the first 2 weeks of the cycle, and median time of onset of hyperglycemia is 2 weeks. These are the recommended management according to the SOLAR study. If fasting plasma glucose is less than 160, we can use the insulin sensitizer like the metformin. If fasting plasma glucose is more than 250, you can use metformin and add pioglitazone. If more than 250 fasting plasma glucose, consider discontinuing the drug and add the insulin. That's the basic management strategy. And this is the mechanism of alpelisib. Basically, it has a direct effect on the glycolysis, glycogen synthesis. Inhibition of the glycolysis and glycogen synthesis leads to the hyperglycemia. Along with that, it has some effect on the GLUT4 receptor, leading to the reduced uptake by the cells. Important thing is, alpelisib have a very short half-life. Most side effects are reversible with the drug interruption and are manageable with the early intervention. Another commonly used drugs, immunosuppressants, are calcineurin inhibitors. That includes the cyclosporin, sirolimus, tacrolimus, and they are used for the prevention of the allograft rejection. They act by inhibiting the calcineurin-mediated T-cell activation. Prolonged use of CNI may cause post-transplant diabetes. Risk factor includes the old age, non-white ethnicity, HCV positivity, and steroid use. Incidence of the post-transplant diabetes is estimated to be 24% at the 3 years post-transplant. This is the basic mechanism of the calcineurin inhibitors. They act by binding on the immunophilin, and they inhibit the calcineurin. That ultimately leads to the reduction in the various beta cell growth factors, causing the beta cell dysfunction and apoptosis. They also cause secretory dysregulation by acting on the GLUT2 and GCK. Apart from that, they also act on the adipose cells and the GLUT4 receptors, and reduces the uptake of the glucose by adipose cells. Probable mechanism is inhibition of the islet beta cell expansion promoted by calcineurin. Sirolimus or rapamycin has another action on the mTOR. It is mTOR inhibitor that is important for insulin secretion and sensitivity. One important point to note is that hyperglycemic effect of the sirolimus is significantly less than that of tacrolimus. So if we switch over the patient from a tacrolimus to sirolimus, hyperglycemia may reduce. Another newer immunosuppressant, that is IL-2 monoclonal antibody, basiliximab, is recently been approved and is used for the acute rejection of the transplant patients. IL-2 plays the central role in the diabetic type 1 diabetes pathophysiology, and therefore basiliximab use may increase the risk of autoimmune diabetes and other autoimmune disorders. There is a transient hyperglycemia, impaired fasting glucose, impaired glucose tolerance, or post-transplant diabetes up to the tune of 42% in the patients who are using basiliximab. And basiliximab therapy and hepatitis C infection is another important independent risk factor for the post-transplant type 2 diabetes. Immunosuppressant corticosteroid, very commonly used, often used. I will not go into the detail, but effect is dose dependent, duration dependent, and route of administration dependent. Older age, history of glucose intolerance, and family history of diabetes are the risk factor for the development of the diabetes. They promote the hepatic gluconeogenesis, induces the insulin resistance, and probably impair beta cell dysfunction. They mainly affect the postprandial glucose, and usually for control of it, you can require either a long-acting insulin, or you can use the short-acting insulin also. This is the possible mechanism of the corticosteroid-induced diabetes. I will not go into detail of this. Another important newer drugs, particularly newer atypical antipsychotics, are associated with the new onset of the diabetes. Prevalence of the diabetes is 2 to 3 folds higher in patients taking the antipsychotics than the general population. In a 2003 consensus statement by the various associations, it was concluded that antipsychotic increase the risk for obesity, diabetes, and dyslipidemia, with the risk of metabolic abnormalities being that closely aligned to the degree of weight gain. So basically, weight gain is the important risk factor with antipsychotics. In a large meta-analysis, it was found that the prevalence of the type 2 diabetes in the people prior to the antipsychotic treatment was 2.9%, and that increased to the 11.3% among those receiving antipsychotics, almost fourfold increase in the development of the diabetes, people who start antipsychotics. Females are more prone to develop type 2 diabetes, as well as the people who are on the multiple drugs or multiple episodes of the psychosis. Diabetes incidence varies between the different second-generation drugs, and highest risk is observed with the olanzapine and clozapine. Women with antipsychotics who conceive are also at increased risk of developing gestational diabetes. Another study which showed that the antipsychotics patients are 10 times more likely to present with the hyperglycemia emergency as a first presentation of diabetes than the general population. And similarly, rate of diabetic ketoacidosis was 30-fold higher in people with existing diabetes with a severe mental illness compared to those with the diabetes alone. So psychiatric illness as well as the antipsychotic drugs can cause significant morbidity as far as diabetes is concerned. Newer second-generation antipsychotic drugs, clozapine and olanzapine, are maximally associated with the weight gain and risk of diabetes, whereas risperidone, aripiprazole, and paliperidone has a significant effect on less effect on the diabetes or glucose metabolism. Higher risk of diabetes and weight gain is associated basically with the high M3 muscarinic effect or H1 receptor affinity. Possible
Sandeep,
mechanism includes the obesity.
Sorry to interrupt, Dr. Sandeep. Could you wind up in the next minute or two?
Yes, sir. Yeah. A possible mechanism includes the obesity, increased appetite, and direct effect on the beta cells. Briefly about other drugs like the antidepressant, tricyclic antidepressants increase the weight gain, induces the insulin resistance. Antileptic like valproic acid can also cause the diabetes by inducing the insulin resistance and the weight gain. Recombinant growth hormone again can induce insulin resistance, weight gain, and growth hormone treatment is found to increase the risk of type 2 development of the type 2 diabetes by 6-fold. Statins, again, we know intensity of the statin therapy is associated with the risk of diabetes, and risk is increased up to the tune of 30%. Niacin, not commonly used drugs. Yeah, antiretroviral protease inhibitors can induce the insulin resistance, and that can cause also diabetes. Fluoroquinolones, not going to detail, can cause hypoglycemia as well as hyperglycemia. Antihypertensive drugs like the beta blocker drugs like the first or second generation drugs can cause diabetes. Antihypertensive thiazides. Clonidine again can cause direct beta cell dysfunction. So in the end, I would say that in all patients on the potential diabetogenic drugs, modifiable risk factors should be identified and addressed, starting with the medical nutritional therapy and therapeutic lifestyle changes. Avoid using 2 or more diabetogenic drugs if possible. If autoimmune phenomena is suspected, insulin, C-peptide levels, and autoantibodies should be obtained. Specific treatment depending upon the pathogenesis should be started. Conclude, many drugs can cause diabetes or worsen the glycemic control in the diabetics. The newly diagnosed diabetes patients who is on the other medications, the possible contribution of drug as a causative agent should be considered. In a patient with the previously well-controlled diabetes, if glycemic control worsens, rule out drug as a causative agent. And drug-induced diabetes is potentially reversible if detected early, except those caused by autoimmune phenomena or permanent destruction of the beta cells. Thank you.
Atul? Okay, Sandeep, excellent lecture. You covered the recent drugs, especially anti-cancer drugs. They're very, very interesting because they are hitting at the insulin glucose pathway and immediately causing the sugar to rise. Atul, would you like to ask one question?
Okay, so Dr. Sandeep, since you have talked about the new kids on the block, the immune checkpoint inhibitors, yes, there are certain other endocrinopathies also associated like hypophysitis and thyroiditis. Would you like to comment on that?
Yeah, almost 2 to 3% of the patient may develop endocrine abnormalities, including hypophysitis, thyroiditis, adrenalitis. And again, these are almost irreversible because of the very rapid autoimmune destruction of these endocrine cells, and they does not respond to steroid also. So once they start, it's very difficult to control them.
So physicians interested in the care of diabetes should not only focus on hyperglycemia, but also check thyroid and cortisol levels in such people.
That's right, sir.
Thank you very much, sir. We appreciate your presence here for this symposium and for giving us a very informative lecture. Thanks again, sir. So with that, we move forward with the next lecture, which is a plenary session. And the topic of this plenary session is the food-based interventions for the management of diabetes. As you know that nutrition is an important part of this symposium and of course the management of diabetes. And we have Professor Jay Kumar Henry, who's joining us from Singapore. Professor Jay Kumar is a senior advisor in the Singapore Institute of Food and Biotechnology Innovation. So he's the right person to talk about these innovations and food-based interventions. Dr. Jay Kumar, over to you, please.
Yeah, Atul, just one point before Dr. Henry speaks. He's a very, very distinguished nutritionist and excellent research. I have been associated with him in European Journal of Clinical Nutrition. So welcome, Dr. Henry, and Dr. Amrita Ghosh is going to manage your system here. So you have to say next to
Wonderful.
Thank you for coming.
Yeah, thank you very much, Professor Mishra, for your very kind words of introduction and also for inviting me here. It's a delightful time to be with you all. So I'm going to start my presentation. Just go back to the first slide, please. First slide, yeah. I'm going to start my presentation by asking you all a rhetorical question. Food-based interventions for the management of diabetes, is it a fact, fiction, or reality? And I want to let you be the decider of that after you hear my presentation. Next slide, please. I'm going to start by taking us all on a historical journey back into the millennia and to remind ourselves that all of our ancestors were hunter-gatherers for millions of years. And during that period, as the term implies, when we were hunting and gathering, our nutritional needs were met by consuming over 100 different plants and animal species. And then suddenly, around 10,000 years ago, we started to domesticate plants and become agriculturalists. And therefore, during that period, you will find that there was an incredible reduction in the number of plant species that we consume. And the last part of this slide is to remind us that modern technology that we know as food technology is only very recent. And in fact, the second part of the slide I want to share with you is that look at the world population was less than 500 million until the turn of the 18th century, when we saw an exponential growth in our population. There is a link between diet and population, which I'll come back to. Next slide, please. This is a very revealing cartoon because out of 300,000 known plant species, about 30,000 are edible, and about, ironically, 30 plant species provide 90% of our calories. And even more amazing is that just 3 provide almost 60% of our total global calories. Remarkable reduction in the number of plant species that we consume. Next slide, please. So if we then add sweet potato, cassava, and corn to this trinity that I talked about a moment ago, we have that it is quite interesting that almost 80% of our population are dependent on these 4 staples. And if we add these 2, it goes to about 90. So the first point, remind ourselves that during the process of transition from being a hunter-gatherer to our modern presence, we have reduced the number of plant species that we consume. But the genius of our mothers, our grandmothers, and food technology is that we can take a single staple like wheat and make over 2,000 different types of food. Reflect for a moment. Your chapati, your puri, your paratha, your cakes, your cookies, it goes into 2,000 different foods from around the world because of the unique presence of gluten. Next slide, please. Of course, our staple rice in this part of the world is only second to none. That single staple has also given rise to thousands of different types of food, of different taste, texture, nutrition, and functionality. Next slide, please. So that's the first part of my reflection, to remind ourselves that the way in which we have moved from large number of plant species to a small number has had some enormous impacts, which we'll talk about in a minute. In the late 1970s, a very famous epidemiologist called Sir Richard Doll in Oxford made a startling statement. He said that almost 70% of all non-communicable diseases that we are surrounded by may be directly or partly attributed to diet. Now that puts diet in an incredible pedestal of reflection, and that's point number 1. Point number 2 is that with the discovery of vitamins in the turn of the 19th century, most of nutrition was therapeutic, meaning if you had beriberi, you were given vitamin B. If you had scurvy, you were given vitamin C. But I think the most important revolution in the nexus between diet and preventive health came with the studies from Ansel Keys, the famous 7-country study, where he showed incontrovertibly that the diet that you consume today can have a spatial and temporal effect tomorrow. And that, again, puts nutrition at the higher pedestal of our scientific reflection. So the question that we're asking within this audience is, can food be the new medicine? Next slide, please. So just to narrative this part of the presentation, We have shown very eloquently that we're using an incredibly small number of plant species to produce our foods. Of course, most of our food is highly refined, and therefore we leach all the vitamins and minerals. And of course, this highly refined food also gives rise to the concept of high glycemic index foods, which is a major focus of my presentation in the context of the topic under discourse today. Last but not least, these 10 to 12 different plant sources remarkably can give rise to a large variety of foods. So a well-stocked supermarket in North America will have 30,000 different foods that are essentially made from these 6 or 7 staples I talked about, in addition to soya oil, palm oil, and our other legumes and lentils. So the point that we are making is that this varietal exposure to human species inevitably confronts us with overconsumption. Next slide, please. So I need not dwell on this cartoon for this August group here, but I want to remind ourselves that if we took the global configuration of about 500 million type 2 diabetics that are around the world, let's not be reminded that for every type 2 diabetic that are diagnosed, there are 2 or 3 undiagnosed diabetics. So the question becomes, how on earth are we going to transform these people from not transiting from pre-diabetics to diabetics by drugs alone? Could a window of opportunity be there for us to use diet as a subvention to extend the truncation of people moving from pre-diabetic to diabetic? And that will be the major thrust of my presentation. And of course, you and I know that the 4 major arbitrators of this number in Asia is China, India, Japan, and Indonesia. And I put Singapore because although it's a small country, 12 to 14% of our population here have diagnosed type 2 diabetics. And as you know, of the 500 million, half of them live in our part of the world. Next slide, please. So remarkably, of the 3 macromolecules that we consume on a daily basis, by 1919, Osborne and Mendel showed eloquently that the presence of essential amino acids made an impact on the quality of protein. And in 1932, from Burr and Burr in Minnesota, they showed that the fats were differentiated by the presence of essential fatty acids. But remarkably and counterintuitively, it was only in 1985 that Jenkins and Williber, both working in Oxford and in Canada, said that the quality of carbohydrates that we consume are not the same, that they can be different, and that gave rise to the concept of the glycemic index. Next slide, please. And I don't need to dwell on this cartoon for this congregation, but just to remind us that what we're trying to do in our dietary paradigm is to try and see whether we can alter the high postprandial glycemia of the food that we consume into a postprandial glycemia that looks more like this. Next slide, please. So my first example is a study we did several years ago, where we used beta-glucan, which, as you know, is a soluble fiber that is found in barley, oats, wheat, rye, and sorghum. But our beta-glucan came from barley. And the next slide, please. All we did was we made some noodles that is widely consumed here. And as you can see here, the top blue line is your delta value for the postprandial glycemia on glucose as a reference. And you can see here the noodle without the beta-glucan. And just 4 grams of beta-glucan produces incredible reduction in postprandial glycemia. Now, of course, this is the example for noodle, but you can imagine with your intellectual imagination, we can add beta-glucan to chapati, to puris, name it what you will. But also the second part I want to share with you is that the reduction in postprandial glycemia in a diet-based intervention is almost what we will get with a frontline drug like metformin. So therefore, we are saying that the food-based intervention have the potential to impact the postprandial glycemia close to or similar to some of the drugs that we consume on an ad hoc basis. Next slide, please. So some years ago, we wrote this review on rice and GI rice products. And I wanted to use this as an aid memoir to remind ourselves that all rice are not high GI. point number one. So therefore, depending on the variety of rice that you consume, and there are, as you know, different hundreds of varieties of rice that we have growing in India. And therefore, the trick is to get your patients to look at rice through the kaleidoscope of variety, rather than giving people an ad hoc presumption that all rice is IGI. Point number one. So you have things like basmati rice, different varieties of rice from southern India that have been shown to have low GI. And the second urban myth I want to also dispel is that all brown rice is not low GI. And I'll come back to why that is in a minute. Next slide.
Professor Henry,
yes.
Sorry, we are enjoying your lecture, but in the interest of time, my humble request, if you could wind up in the next 2 minutes.
2 minutes? No, I've been given 25 minutes.
Dr. Atul.
Okay, I'm sorry, I got it wrong. Right, I'm sorry.
10 minutes. Dr. Henry, you have 10 minutes.
Right,
Thank you.
Sir. Sorry.
Yeah, I'm on time. Don't worry. Yeah. So we have known from the work of Gannon many years ago that when we co-ingest a protein with a carbohydrate, some of the proteins produce an insulinotropic effect, and therefore it reduces glycemia. So we want to ask a question: are all proteins made the same? So we give people 50 grams of available carbohydrate in the form of rice, co-ingested with soybean curd, with fish, with egg white or chicken. And the reason for that is that, as you know, egg white has got a complete battery of essential amino acids. It's a complete range of essential amino acids. Chicken popularly consumed, and so is fish. And soybean curd widely consumed in this part of the world. Next slide, please. So quite contrary to our intuition, it turns out that the protein that gave the best effect of reducing glycemia was not egg white, but was soya. So it turns out that you can see that soya protein is deficient firstly in methionine and then cysteine. So therefore, the presumption that complete amino acid profile proteins have a better effect on glycemic response is not true. And therefore, the good part is that therefore you can say in our part of the world, we can substitute soya bean for any other lentil that you can also consume. That tells you that co-ingestion of a lentil or a legume with rice or chapati is the best thing. And thank goodness that our mothers had the culinary intuition to always give us chapati with lentils and rice with dal. And that's a remarkable thing that also has got a scientific rigor and veracity. Next slide. So that was a whole meal I talked about. We asked the question, what about using protein isolates in a very popular beverage that is quintessentially consumed in all parts of the world, which is a milkshake. So what we did was we had a control milkshake with little or no protein. This is a milkshake with oat protein isolate, pea protein isolate, or rice protein isolate, and we had sucrose as the source of carbohydrate. Next slide, please. And again, you can see some interesting results. The best protein isolate that reduces glycemia compared to the control, surprise, surprise, is rice protein and pea protein. So here's again another counterintuitive proposition, which is that rice protein is deficient in threonine and lysine, and of course, pea protein is deficient in cysteine and methionine. So it turns out in the paradigm of glycemic control, proteins that are deficient in certain amino acids seem to have a better response than completely isolated protein sources. Next slide. The same, we asked the question in the interest of time, let's move on. Let's move on in the interest of time. So for over 15 years, we've been using the continuous glucose monitor, not for clinical research, but for basic human research. You can see how archaic our machine has been, but we've got a more refined machines now. I want to move to the next slide. And so we gave people on a crossover trial a low or a high GI breakfast, which was made of rice. And I want to share with you the glycemic trace. Next slide. So not surprisingly, subjects are given on a crossover trial or a low or high GI rice, and not surprisingly of the high GI rice, the post-glycemia was higher. What we then did was we exposed them to an ad libitum lunch, and much to our delight and surprise, those that were given a low GI breakfast on their own volition and in their own decision-making process were selecting less food and therefore less carbohydrates. So what did that do? It meant that the entire glucose excess through the entire day was down-regulated compared to the one that was given the high GI impact. So it looks like feeding a low GI breakfast not only has an effect on your glycemic response, but also on your appetite control in a way that we are not seeing. And let's look also at the fasting blood glucose at the following day. It's about 0.5 to 0.6 millimoles low. Next slide, please. Why is that important? It turns out that just like a TG and a cholesterol, we may need to ask our patients to say, even if you are a pre-diabetic, try to have a fasted blood glucose much lower than you can, because it has got a surprisingly linear connectivity between risk of stroke, heart disease, and cardiovascular death. Next. I want to move quickly to two examples of chronobiology of nutrition, which actually is a very hot topic, to ask the question, is there a best time to eat a meal during the day? Or what the sequence of eating foods within a meal? And I'm going to give you two examples of that. Next slide, please. So here you are. We have given, those who have been to Singapore and this part of the world, we know we are very, very accustomed to eating something called a chicken rice. Chicken rice contains a bowl of rice, a piece of chicken, as the term implies, and a piece of vegetable. I want to draw your attention to this slide here. So in the chicken rice, if I ate the vegetable first, and then the meat, sorry, let me start again. If I ate the rice first, this one here, rice first, then the vegetable, and then the meat, I had the highest postprandial glycemia. But look what happened if the same meal is ordered in a different sequence, where I ate the vegetable first, then the meat, and then the rice. The postprandial glycemia is incredibly reduced to if I ate the rice first, the vegetable, and the meat last. What is the mechanism? It turns out that the vegetable increases your transit time of gut motility, and the protein triggers your insulin secretion. So this is a very interesting observation. You don't need to do much in your diet therapy except to change the sequence in which we need to eat the food. So that's point number one. Point number two is a paper that we published a few weeks ago in, next slide please, in the BMJ, where we asked the question, what would happen if I gave people an identical test meal, a high GI or a low GI meal, at breakfast or at dinner, so the same meal. And in order to deflect the preload criteria, we gave everybody a standard meal before the test meal at supper or at breakfast. Next slide, please. And this is what we get. The red line shows you, not surprisingly, if I gave you high GI dinner, the postprandial glycemia is very high. And at dinner, if I gave the low GI dinner, it was much lower. But what is quite remarkable is the identical meal I gave you at dinner, if I gave you at breakfast, it is even lower than the low GI dinner. So the main message is that the glucose flux at breakfast is much more attenuated than the glucose flux at dinner. And I'll come back to this point in a moment. Next slide, please. So what are my summary points? Of course, I've not had a chance to share many of the other research from Dr. Mishra's group and many others in India, but you can say rice and wheat remains a major source of energy, protein, and macronutrients to millions around the world. The glycemic response of rice varies considerably. Choose those rice that are like basmati and numerous varieties found in India. Simple methods of co-ingesting rice with meat and vegetable can dramatically alter your glycemic response. The sequence in which we can eat rice have a significant impact, which again is something that is easy to advocate. Next slide, please. Always consume rice as a source of protein and vegetable. Soya protein and other legumes have a great impact on reducing glycemia. Dairy products, soy milk, and other forms of vegetable milks can also have an impact on glycemia. This is a very important point. Try to eat small portions because the mastication time is smaller and therefore the particle size of the carbo are larger and you get a much lower glycemic response. Next slide, please. The most significant meal of the day is breakfast. Key point, never avoid breakfast. Try to eat a low GI breakfast, small in quantity, that will set the stage for your postprandial glycemia through the entire day. An identical meal given either at breakfast or dinner has different impacts, which I saw a moment ago. And I think it's, remember the old English adage, eat breakfast like a king, lunch like a prince, and dinner like a pauper. Unfortunately, in India and all parts of Asia, we eat like a king at breakfast, lunch, and dinner. Next slide, the last one. The recognition that carbonate quality or GI is important, I think, of modulating glycemic response is a significant observation in human nutrition. I also think that the GI and the quality and quantity of carbonate becomes much more important to our Asian phenotype than the Western people, where they don't eat such a high carbohydrate diet. And finally, I believe that we must continue this research on trying to make food the new medicine. Last but not least, let us be proud to be reminded that India was the epicenter of the concept of food the new medicine from the time of our Vedas 5,000 years ago. Let us re-establish and have a renaissance of this. And thank you very much to you all.
Thank you, Dr. Henry. Atul, we have time for one question, and I will. Atul, are you there?
Yes, sir. Yes, sir.
Please ask this question which Dr. Sanjeev Gulati has asked.
Right, sir. So, Dr. Sanjeev Gulati has asked this question about, I think he joined a little late, so he might have missed the point about the type of rice which we eat, brown rice, basmati rice, or polished rice. So how would that impact the glycemic index of the rice meal?
Very good.
Black rice.
Black rice, yes.
Actually, the real black rice that we find coming from North America is not actually an Oriaceae species. It's not a rice species at all. So actually, it's a different species. So number one. Number two, I think the presumption that all brown rice is low GI is not true. It also depends on the level of milling, because it turns out that some of the micronutrients, especially in the bran and the alluron layer, may have an effect on glycemic response as well. So I think it's important for us to really get good data on the rice variety, which I think India is abundantly rich with different varieties, and that's the key to giving advocacy to our patients.
Right. So from Professor Mishra and Team CDOC, we thank you profusely, Professor Henry, for giving us such a wonderful insight into nutrition-based interventions in diabetes. And we hope you stay safe and stay well in Singapore. And we'll always have you over whenever we have such deliberations.
Thank you.
Thank you very much.
Thank you so much.
Thank you. So for the next lecture, it is my privilege and pleasure to call upon Dr. Sanjeev Gulati. Welcome, Dr. Sanjeev Gulati. Dr. Gulati is a senior teacher and clinician in the branch of nephrology. Currently, he's the director of nephrology at Fortis Hospital, Vasant Kund. So he's a friend and colleague, and he has the unique distinction of being equally at home with adult nephrology as well as pediatric nephrology, with his vast knowledge, experience, and qualifications. And he will be talking to us about SGLT2 inhibition and renal protection. So the stage is yours, Dr. Sanjeev.
Thank you, Atul, and good morning, friends. At the onset, I'd like to thank Professor Mishra, Team CDOC, for giving me this opportunity to participate in the annual Ahuja Bajaj Symposium. I think it's one of the finest meetings in diabetes over these years. It has established its credentials, and it's credible that despite the pandemic, we have chosen to go on. The topic that has been given to me is the SGLT2 inhibitors and renal protection. And I would like to add that these are truly the game changers that have emerged over the last few years in cardio-nephrology. Now, when I think about these drugs, I'm reminded of this quote which I picked up from late President Kalam's book, Wings of Fire. The actual quote is by Alvin Toffler, and it says that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. And in that sense, I think SGLT2 inhibitors is what is literacy in diabetes is all about, and you cannot afford not to know about these drugs, which will really change brought about a sea change in the management of diabetes, diabetic kidney disease. Now, our interest in diabetic kidney disease goes back to my time at SGPJ. We were among the first groups, as you can see, our paper highlighted that diabetes was emerging um, as one of the commonest causes of end-stage kidney disease in our patients. And when we looked at patients more than 40 years, at that point of time, it had already emerged as the commonest cause. Subsequently, this data was validated by studies from PGI Chandigarh and Apollo Chennai by Dr. Mani's group. Now, just to quickly remind ourselves, about 2 out of 3 patients of type 2 diabetes would be at risk of developing diabetic nephropathy. 1 out of 2 to 3 patients of type 2 diabetes would be affected by chronic kidney disease. We also had the eye care for diabetes survey, which showed that 1 out of every 2 type 2 diabetic patients has chronic kidney disease. And to add to all this, Dr. Shah's study shows that South Asians are at highest predisposition for chronic kidney disease as compared to Caucasians, a 4-fold more likely to develop albuminuria and about 1.45 times higher loss of GFR. So when we are talking to our patients, it's very important to keep this in the background and while we are choosing amongst the plethora of anti-diabetic drugs. Now, diabetic kidney disease, we all know, has serious consequences. There is impaired cognition, there is cardiovascular death, cardiovascular events, renal events, and increased mortality. So it's a big price to pay, and a lot of times we are in a dilemma as to should we add this drug because it's a bit expensive, but we need to keep in mind that this patient is going to pay a big price. So no drug, any drug that is good, has got excellent renal protection, is worth its money in gold. Now, let's look at the pathophysiology of diabetic kidney disease. Diabetes causes glomerular hypertension. So this is the afferent arteriole, this is the glomerulus, this is the efferent arteriole. These are the SGLT2 inhibitors in the proximal convoluted tubule. So these are the sodium glucose transporters. And in normal circumstances, the glucose is reabsorbed. Along with that, the sodium is also reabsorbed in the proximal convoluted tubule. And so there is afferent arteriolar dilatation, and this causes glomerular hypertension. So the higher the glucose load, the greater the sodium absorption and the greater the glomerular hypertension, which sets into process downstream events leading to cellular damage. So this is glomerular hypertrophy that is happening, and there is glomerular hyperfiltration. So the day the patient develops diabetes, these changes have already set in. And these are the renal hypodynamics under hypoglycemia. Okay. Now let's look at what these SGLT2 inhibitors do. We all know that they block the SGLT2 receptors in the proximal convoluted tubule. So this is a diabetic glomerulus. There is afferent arteriolar dilatation. So because of this blockage, there is less glucose reabsorption in the proximal tubule, which is manifested as glycosuria. But along with that, as you can see, there are more sodium also that is being lost here in the urine. And when this sodium reaches the macula densa, which is the nerve control center as far as the nephron is concerned, there is an afferent arteriolar constriction. So there is actually at the cellular level a reversal of the pathophysiological hemodynamical changes that is happening because of the hyperglycemia. And there is, in the early stage, there is a reversal of glomerular hypertrophy, and there is stabilization of the glomerular filtration rate. So this is a summary of the potential mechanisms leading to renal protection with the SGLT2. There are a lot of pleiotropic effects because of glycemic control, and which is why we are seeing, that they have emerged as among the first-line drugs as far as diabetic kidney disease is concerned. So I'll take you through the various trials. The first is the Credence trial, which with canagliflozin, and as you can see, this is the forest plot analysis. And what the Credence trial showed was that the patients who were on the cana arm, there was benefit as far as doubling of serum creatinine was concerned, progression to end-stage kidney disease was concerned in terms of patients progressing to EGFR less than 15, progression of patients to dialysis, renal death, cardiovascular death, and with ESKD, doubling of serum creatinine or renal death, or whether dialysis, kidney transplantation, or renal death. So it was quite an eye-opener, and everybody was amazed at the results. This was followed by the EMPIRE trial, and in the EMPIRE trial, more or less mirrored what was shown with the canagliflozin arm. The side effect profile was a bit different for sure, but it showed that there was reduced chance of new or worsening nephropathy or cardiovascular death, reduced new or worsening nephropathy, reduced progression to microalbuminuria. As you can see, all these plots are to the left. Reduced doubling of serum creatinine, reduced chances of initiation of renal replacement therapy, and when all of these were combined, still there was a significant benefit towards the left, favoring the empagliflozin arm as compared to the placebo. And this was another post-ad hoc analysis of the EMPIRE outcome in patients with or without proteinuric diabetic kidney disease. They also looked at the Credence-like subgroup, the GFR between 30 to 90, and microalbuminuria, as well as and there was a non-Credence subgroup, and the benefits were maintained in the Credence-like subgroup also. Next came the DAPA-CKD trial, and the DAPA-CKD, unlike the previous trial, was the first dedicated renal outcome trial to assess the efficacy and safety of an SGLT2 inhibitor in patients with chronic kidney disease with and without type 2 diabetes. So it included patients with chronic kidney disease which were not due to diabetic kidney disease, to test the hypothesis whether there was some independent renal protective effect. And the results were again astounding. 39% relative risk reduction for the primary composite endpoint, that is more than 50% decline in the GFR, end-stage kidney disease or cardiovascular death, 44% relative risk reduction for the renal composite endpoint, 29% relative risk reduction for composite cardiovascular death, hospitalization, heart failure, 31% relative risk reduction for all-cause mortality. And the consistent treatment effect in patients with CKD across major subgroups, including in patients with and without type 2 diabetes, and by baseline EGFRs and urine albumin creatinine ratios. DAPA was well tolerated for the treatment of chronic kidney disease, and data confirm the known safety profile. The DAPA-CKD builds the evidence for DAPA in the prevention of heart failure and worsening of kidney disease, and the declare and reduction in the risk of worsening heart failure and cardiovascular death in the DAPA heart failure trial. So again, telling us that this was actually a class effect rather than a drug effect. The DAPA, the findings were so remarkable that the DAPA-CKD trial had to be stopped midway because of the overwhelming benefit in the DAPA arm. And just last week we had this subgroup analysis of the Credence trial looking at efficacy of cana in patients with the EGFR less than 30. Now, this is a goal point that is constantly being changing. In the Credence study, these patients were studied up to 30, so more than 30 were taken. In the EMPIRE trial, it was up to a EGFR of 40. The DAPA again lowered the cutoff down to 30, and this is actually taking it even further. So the study question was, what are the effects of cana in patients with type 2 diabetes and baseline EGFR less than 30? Were the benefits sustained? And let's look at there were 174 patients in the Credence trial which had an EGFR less than 30. This was the mean EGFR 26.5. This was the mean urine albumin creatinine ratio, and this is the placebo arm. As you can see, the mean rate of decline EGFR was minus 3.83. And what was remarkable here was that even in patients with stage 4 kidney disease, there was benefit effect of canagliflozin. The rate of EGFR decline was minus 0.3. Again, the other outcomes were more or less similar, whether the GFR was more than 30 or less than 30 in terms of kidney failure, AKI, adverse events. So this study, which has just been published in the November issue of CJASN, showed that canagliflozin slowed progression of kidney disease without increasing acute kidney injury, which has always been an apprehension in us, that even in patients with diabetes and EGFR less than 30. So these are the kidney outcomes, just a summary of the SGLT2 outcome trials, consistent improvements in renal outcomes across SGLT2 inhibitors. A summary, this is the EMPA-REG outcome study, the DECLARE-TB trial, the CANVAS program. These were all, mind you, primary cardiovascular outcome trials. There were subsequent post-ad hoc analysis was done. The Credescence was the first dedicated kidney outcome trial, followed by the DAPA-CKD trial, and this is the dedicated heart failure outcome trial showing the DAPA heart failure, again, where they found that there was benefit. And these are the
Dr.
key
Gulati,
outcome trials.
Dr. Gulati, sorry, just if you could wind up with the
Yeah,
next.
this is my last slide. So
thank you very much. Thank you.
Yeah, so this is the DAPA-CKD trial. This is the Credence trial. The EMPA kidney trial with empagliflozin is ongoing. And as you can see, both the DAPA-CKD and the Credescence trial showed overwhelming benefit of SGLT2 inhibitors as far as renal protection is concerned. So if I look into the crystal ball and gaze into the future, I think we are looking at dual SGLT2 and RAS inhibition, and they are going to be synergistic, because as I showed you that this is the SGLT2 inhibition, it acts at the efferent arteriole. There is vasomodulation happening, there is decreased glomerular pressure, there is reduction in albuminuria, and there is renal protection. And whereas the RAS blockade acts at the efferent arteriole, there is decreased glomerular pressure, there is reduction in the albuminuria, and there is renal protection proven in clinical trials. And we now have these agents which is going to act synergistically at the afferent and the efferent arteriole. There is potential for normalization of the intraglomerular pressure, there is additive intraglomerular pressure reduction, and there is immense potential for long-term renal protection. And not surprisingly, based on this overwhelming evidence, we can see the SGLT2 inhibitors, whether it is the ACE guidelines, whether it is the ADA standard of cares, they have moved up the ladder to emerge as one of the frontline drugs as far as management of diabetic kidney disease is concerned. And I end on this note that in water is the origin of life, the kidney preserves the sea in us. We must preserve the kidney using our skills widely. This is the unique role of renal physicians or nephrologists. And at last, we have a newer group of drugs, namely SGLT2 inhibitors, who will go a long way in helping us achieve our goal. Thank you.
Thank you, Dr. Gulati. Thank you very much. And as always, you have always impressed us for your knowledge and oratory skills. So if I may just ask one question, something which intrigues me, that DAPA-CKD showed up that it is not only diabetic nephropathy, but even non-diabetics benefit. Now, my question to you is, with your vast experience, would you expect a similar benefit in non-diabetics with tubulointerstitial disease and not a glomerulopathy?
A very interesting question. So now if we look into, I'll take you back to the pathophysiology as to what happens in chronic kidney disease. There is a glomerular hyperfiltration occurring because of loss of renal mass. And once the kidney disease is advanced, whether you are dealing with a chronic glomerular disease or chronic interstitial disease, the pathophysiology that is going on is more or less similar. So my hypothesis is that because these reduce the glomerular hyperfiltration, the benefits are going to be there even in chronic interstitial disease. Although I agree with you that in the DAPA-CKD arm, they had taken patients with chronic glomerular diseases. But yes, these are exciting times, and I'm sure we are looking at more studies on the horizon from the nephrologists now who have learned from the diabetologists as to the immense potential of these SGLT2 inhibitors in the management of chronic kidney disease.
Yes, so the nephrologists like you and the cardiologists too are really sneaking in with this molecule and taking it away from glycemic control, which is the focus of diabetologists. Anyway, so thank you, Dr. Gulati, once again. We appreciate your presence here and a wonderful lecture. Thank you once again.
Thank you, Atul, and thanks to the team CDOC once again for giving me this opportunity.
So I can see Purva Guliani has joined in, and so she's coming up with the next lecture. Purva is joining us from Victoria, Australia. She's a senior nutritionist, and interestingly, she is also the community health advocate for managing chronic disease in Southeast Asians and migrants in Australia who are of South Indian origin. So she's bringing Mediterranean diet from the Europe to India through Australia. So welcome, Purva, and we look forward to your inputs on how to Indianize a Mediterranean diet, the benefits of which we know very well. Over to you, Purva.
Welcome, Purva.
Thank you, sir. Thank you so much, Dr. Atul, for this wonderful introduction. And thank you so much, Dr. Anoop and the entire team for having me over. It's a pleasure to be here with such esteemed speakers today. So without wasting further time, today we're going to talk about how to Indianize the Mediterranean diet. And these are the main objectives that we're going to cover today in this session. So starting with the nutrition transition in India, I'm sure a lot has been talked about the double disease burden that India is facing at this point of time by all my other esteemed speakers and colleagues. So yes, we do agree that chronic disease management is something that we really need to work on, and cardiovascular disease tops the chart on the disease burden for that. So nutrition transition has played a very important role in this chronic disease management. And I have this paper by Professor Mishra only, which I always refer to, and I'm referring here in while doing my PhD also, which talks about that how, along with genetic predisposition, the improper diet and increase in the sedentary lifestyle is the relationship, is the chronic relationship between the diet-related non-communicable diseases such as cardiovascular diseases, diabetes, and obesity. So what do we do with it? What is the solution for this? Keeping that in mind, WHO had developed HUTS, which is basically a program. It is an evidence-based program, strategic program about managing cardiovascular diseases in the primary healthcare setting. And as you all can see, that healthy lifestyle counseling comes on the top of it, which includes your diet, your physical activity, and the entire lifestyle. So diet, the importance of diet, the role of diet has always been advocated by all the health professionals. And now here, if you search internet, as you know how everything is all Google, and people prefer going there rather than coming and seeking advice from health professionals at times. So if you search, or if I researched about which is the best diet and why, the Mediterranean diet has popped up, and it has been named the best diet for the past 3 years, consecutive last 3 years. Then what is this Mediterranean diet? This term Mediterranean diet was coined in 1960 by Ansel Key and his wife Margaret. They were working a lot on cardiovascular diseases. And it is basically the diet which is followed or which is applied by people who are living along the Mediterranean Sea, along the coast of the Mediterranean Sea, as the name suggests. And the most interesting part is that dieta in Greek is not just food. It is a complete lifestyle. It's a complete different way of living. And yes, as Dr. Atul just said, that we know the benefits of Mediterranean diet, and it has been proven in a lot of studies, such as this EPIC cohort, where we had 32,000 plus Italian participants, and they were followed up for 12 years. And when they adhered to the Mediterranean diet, they saw that they could prevent weight gain and even abdominal obesity. This is one of very good studies. And another very important study on the Mediterranean diet is the Intermittent, which is the largest prevention trial, and it talks about the benefits of the Mediterranean diet in decreasing the incidence of the chronic diseases in people who are already at risk of cardiovascular diseases. And it was conducted in Spain with 7,000 plus participants, and the results were significant, approximately 30% reduction in the combined endpoint of heart attack, stroke, and cardiovascular health. And along with that, there are a lot of more studies worked on Mediterranean diet these days. That is the reason why even American Heart Association has recognized and acknowledged Mediterranean diet as one of the best diets for preventing chronic diseases and overall a very healthy lifestyle. Apart from all these studies and a lot what's happening, I really like to put light on this study because this talks about what is so special about the Mediterranean diet. It sums it up beautifully than what all has been summed up and researched in all the other papers. And this is talking specifically about the diet in the Greece, people who live in Greece, what they follow. And it tells us that how these factors such as balanced essential fatty acid intake, which is so important from all the different sources, whether it's vegetable intake, marine, animal, and most importantly, the perfect ratio of omega-6 to omega-3 fatty acids, which is 2:1, which is as compared, if you look at the other European diets, it's close to 15:1, and American diets is 16.74:1. So this, along with this, the Mediterranean diet is a powerhouse. It's a storehouse. It's abundance of all the antioxidants and the phenols, which overall together help in protecting the heart. So this is really, really important for us to know that why do we recommend the Mediterranean diet? And now, very importantly, what does the Mediterranean diet, or how does it look like? This pyramid sums it up very beautifully. Now, as said before, that it is not just a diet, it's not just what you eat, it is all about the lifestyle. And this shows in this pyramid itself. If you have a look here at the bottom, the most important emphasis has been given to your lifestyle, which includes physical activity, your rest, the way you eat, your socialization, are you using eco-friendly products or not? So this makes the major base or the major chunk of the Mediterranean diet. And then comes the role of plain water or herbal infusions as your main source of fluids, not the beverages or the sweetened beverages and juices and all. After that, the base there, this is divided into three main things. Certain food products are supposed to be consumed in every meal. Yes, in every meal. And a lot of people may be surprised to hear about the breads and the oils, but yes, definitely it is every meal here. So things like extra virgin olive oil and breads, rice, pasta, or other coarse cereals are recommended, about 1 to 2 serves of them in each meal, along with 2 or more serves of vegetables and 1 to 2 serves of fruit. So basically more variety, more color, more texture. And importantly, you could use cooked and raw, a perfect combination of both. Up next, there are certain foods that are in the everyday category where they're supposed to be utilized on an everyday basis. There comes the role of herbs, spices, garlic, and onions. I'm already hungry, but yeah. So, and definitely adding less salt and giving more flavor to your food by these natural herbs, along with the nuts and seeds. And dairy is recommended to 2 serves, not more, and preferably the low-fat version of the dairy. And if we look at the weekly structure, things like potatoes, white meat, or eggs are recommended into the 2 to 4 serves per week category. Whereas if you look at the fish, seafood, and the legumes, they are recommended as 2 or more serves per week. But red meat has been restricted to 2 or less serves per week, and definitely processed food has been restricted to 1 or even lesser per week as the weekly intake. Now, talking about the sweets are basically all your cakes, pastries, and the store-bought stuff. So they're talking here about 2 or less serves per week for this for the sweet section. With wine, the recommendations for the Mediterranean diet is in moderation, and a glass of wine is recommended with the meals. But for people, there are certain people with religious beliefs who would not, or social beliefs who would not want to do that, because in the southern part of the southern Mediterranean part, their black tea is the main source of the polyphenol. So they would not have wine because of religion beliefs. So it is respected there. As I said, it is all about the lifestyle. So this is a perfect summary of what a Mediterranean diet looks like. And now here we have the MIDAS, which is the 14 question survey, which was developed in the Pyramid study itself, which talks about, is your client adhering to the Mediterranean diet or not? So assessing the diet intake is so very important. And this is a perfect example for that. Anybody who's trying to practice Mediterranean diet should definitely have a look into this. Now, we had a look at what the Mediterranean diet is. Now let's talk about the Indo-Mediterranean diet and why do we need it? That's the most important thing. Cost, affordability, availability of the products, and sustainability. I think all these three things go hand in hand. There are a lot of products which would not be available as recommended in the Mediterranean diet itself. That is why we need a little modification to the Indianized version of it. Next, the liking and the taste preferences. Yet we need to develop the taste for wine or olive oil, etc. And definitely our cultural and religious beliefs and differences. India is such a multicultural country where every state has a different cuisine, every state has a different language. So there, comes the role of whether people would like it, enjoy it or not, and what their beliefs are. So that is really important. And last but not the least is the lack of knowledge. Mediterranean diet is way more than just having olive oil in the diet. So I think a complete knowledge and information is very, very important and very crucial for that. Now, there haven't been a lot of studies done on the Indian population adhering to the Mediterranean diet or the role of the Indianized Mediterranean diet and their effect on the heart health. But now here, I would really like to point this study out by Ram Singh et al., which talks about the role of, they were given an Indo-Mediterranean diet to 499 people, where they increased the fruit and the vegetable intake along with the nuts, and more of the whole grains, legumes were increased, and the olive oil was swapped with mustard seed and the soybean oil. So after this, and this was compared with the control group was, which followed the step 1 and step prudent diet. So at the end of 2 years, when they evaluated this, so there was a significant decrease in the total cholesterol and LDL and triglycerides for both the group, but it was larger in the Mediterranean group, in the intervention group, and the HDL levels were significantly increased in the intervention group. So definitely this proved that Mediterranean diet has a little upper edge as compared to the standard NSEP diet in preventing the chronic disease, especially heart disease in the Indian population. Now, how to...
Purva, could you conclude in the next 60 seconds?
Yeah, this is the last slide.
Thank you.
So this is where, like, how we're going to Indianize the Mediterranean diet. So I won't go much deeper because we just have 60 seconds. So here, the extra virgin olive oil could be easily swapped to mustard oil, rice bran, groundnut, and soybean, like as it has been recommended, a combination of oils. And a lot has been done, a lot of study has been done and proved upon the benefits of this a bunch of oils on the Indian diet, and it's palatable to us. With wine, unfortunately, not a lot of study has been done on the alcohol and the cardiovascular risk in the Indian population. Though the Interheart study said that, which was done for the 52 countries, it said that it did not help the Indian population much. But wine, wherever possible, great. But otherwise, we do have the black tea options because wine is generally a rich man's drink here in India still. So black tea would be a wonderful option again there. And all the herbal tea infusions, natural herbal tea infusions, such as the fennel, carom seeds, fenugreek, all these could be included very well in our daily diet. And with the fish, it is again region and religion dependent. So if people are not able to have fish, or if fish is not a part of their culture or diet, then flax seeds, chia seeds, walnuts, or even supplements if needed as recommended. And pulses, we're great. We have a lot of pulses in our diet. We're lucky because here in Australia, I teach clients that to eat pulses because it's not there in the part of their cuisine, but the consumption is decreasing. That's what the data suggests. Similarly, for the cereals and the fruits and vegetables, The data suggests that the consumption is decreasing. So as health professionals, our main role would be as stakeholders and policymakers to encourage the pulse, cereal, and fruits and vegetable consumption, and mainly focusing more on seasonal, more on locally available resources, and including the whole meal versions, whole meal beans, and whole meal grains specifically, and vegetable and fruits, mainly including the fruits itself rather than the juices, and more variety, not just sticking to one or two particular things that they like, the variety, and having a right balance of cooked and the raw vegetables in the diet would be very crucial again. And with nuts, and the last very important point here is, which I would like to touch on, is about the use of onion, tomato, garlic, and olive oil based dishes in that cuisine. So we are lucky here again, because that is an integral part of the Indian diet also. But yes, definitely it needs to be worked on with less amount of fat and less amount of salt in the diet itself, along with even chicken, lean sources of that, and to be substituted with more legumes for someone who is a vegetarian, and include more soy-based products and low fat and low sodium content. So thank you so much. I hope I was on time.
Thank you very much, Purva. And I second the several opinions which have come in the chat box. That was a wonderful presentation, concerns all of us. As metabolic physicians, we need to know about how to practically implement the knowledge and science into our day-to-day patient care. Thank you very much. So,
Can
yes,
I
Dr.
make a
Yes.
point, Atul? Purva, excellent talk. Your last slide was very good. And any of you, any of the audience, if they want the last slide, would you be able to
Sure, sir. Sure. I am happy to share the whole presentation, sir. I will send it to you.
All right. Any of the audience who are interested, please email Koel Datta, KOELDUTTAC @gmail.com, where you can ask for a free copy of book and Dr. Purva Gulyani's the presentation. And there are a number of questions in the chat box. Purva, please answer them separately in the chat box because of lack of time.
Sure, sir. I will.
Thank you. Atul, can you carry on?
Yeah. So from now on, I can see the welcome, Dr. Neeta, and pleasure to have you here. And I think I will now hand over to Dr. Alka Jha to carry on with the rest of the symposium. And so Dr. Alka will be introducing. Dr. Alka, are you there?
Alka?
Oh, I think I don't
see. Okay, I'll you know.
Can I do that, sir? Can I do that, sir?
Yeah.
So we welcome for the next lecture Dr. Neeta Deshpande, who is a diabetologist, physician, obesity specialist, bariatric physician, and with a very keen interest in nutrition, weight management, and of course, clinical diabetology. And she's joining us from Belgaum, Karnataka. And she'll be talking about a very pertinent, well-discussed, and a very relevant new topic of intermittent fasting. And she'll take us through what is the evidence. So what are we talking through our hats, or is there real evidence? And we look forward to your lecture, Dr. Deshpande, and the stage is yours, please.
Thank you, Dr. Luthra, for the kind introduction. Am I audible?
Yes, you are.
Yes.
At
the outset,
slide, please.
Yeah. Thank you very much, Dr. Mishra, for having me here, and I shall share my screen now. Give me one moment.
Yes, your slides.
Yeah.
Your slide. You can go to the slideshow. Yeah, we are done. Yeah. Good. Please.
So I'm going to be talking in the next 12 to 14 minutes about intermittent fasting, what evidence we have. And this is a raging topic, as Dr. Luthra just mentioned. And the reason that it is so is that we often find that as far as diets are concerned, there is a new concept that is proposed by a professional community. Say it may be a keto diet, it may be intermittent fasting, whatever it is, something, maybe it is an old concept that is, brought in again. But what happens is it gets hijacked by non-professionals, and then it becomes a fad diet. And then it is used very injudiciously. And there are detrimental effects that are reported because it is not used by professionals. And because of these detrimental effects that are reported, what happens is it's a vicious cycle. And then the professional community actually becomes skeptical about it, but perhaps there is something in it, and because of which the patient gets deprived of a potentially beneficial strategy because it is used by all and sundry. And that is how some diets which could prove to be useful just get thrown out of the window. So is intermittent fasting something like that, is what we are going to see. I'm going to try and give you the latest evidence that we have so far on this. So let's try to actually differentiate between the myths and the facts. Let us first know what it actually means. We know that fasting as a process has long been integral to many religious and ethnic cultures. All of us know about the Chaturmas, we know about Ramadan, we know about all these things. Every religion has it in some form or the other. But intermittent fasting, as it is practiced today by some physicians or some specialists, has many forms. But suffice it to say here that the basic premise involves taking periodic breaks from eating. So it could be alternate day fasting, it could be 16 hours of fasting, 8 hours of eating, or 18 and 6, or it could be 5:2 where you eat for 5 days and fast for 2 days, or there's alternate day fasting. Many forms are there. But having said that, when you look at the clinical trials, it's not easy to actually interpret the data because dietary strategies are not easy to study, not easy to report. So there could be many fallacies in the trial conduct itself, and hence the guidelines are late in coming. So you will find that many of these do not become guidelines for years together because they're not studied well and they don't come into the mainstream. So this is just a short slide to tell you what actually happens when you consume food and what happens when you are fasting. So in the fed state, the important part here is that glycogenesis happens until its capacity is met, which means that there is a limited capacity for glycogenesis. Anything excess of that gets stored as fatty acids in the adipose tissue. In the early fasting state, we know that there is gluconeogenesis that is happening, and there is glycogenolysis to generate glucose. And then after a while, there is initiation of lipolysis. If the fasting continues, then there is a metabolic shift, and fatty acids and ketones become the fuel in preference to glucose because glucose is not there during the fasting period. And then this is the absolute starvation state. So this is the basic physiology and the premise under which intermittent fasting is practiced. So there are many studies actually that have been done. Some are small, but the problem with interpreting intermittent fasting studies and reviews is that different kinds of fasting on time restricted eating, all of them are bunched together in many of the studies, and hence it becomes difficult to interpret. Having said that, this is one of the earlier studies that came in this decade, which found that there was weight loss and various biomarkers were affected beneficially. And it was in this particular study, it was as effective as continuous restriction. Then you will ask me, if it is okay, is as good as continuous restriction, why should you not just do continuous restriction? Well, for one, intermittent fasting is easier to follow because when you're fasting, there is no question of deciding what to eat. It is just fasting. And then during the eating period, you can be a little more lax, but not completely relaxed. And that is how they say that it might be easier to adhere than just continuous restriction 24/7. So there are other studies also which talk about the metabolic effects, and this is a 2017 review. And you can see that this review has given us data that intermittent fasting regimens are hypothesized to influence metabolic regulation via effects on circadian biology, the gut microbiome, which is something that we are talking about all the time for both diabetes and obesity, and modifiable lifestyle behaviors such as sleep. We also know that sleep affects obesity and diabetes. So all of this could be favorably modulated by different kinds of intermittent fasting. And this review very elegantly shows us some evidence about the metabolic effects of intermittent fasting. I'm going to now just take you through very briefly through studies between 2003 and 2018 of different kinds of RCTs and different kinds of intermittent fasting. In all of them, the underlying thing the result that I can tell you about is that it did cause weight loss and it did cause fat loss as seen by various parameters such as waist circumference, etc. And the summary of it all was that there was weight loss, there was a fat loss. It favorably affected a lot of the inflammatory biomarkers as well as the lipid profiles. And you can see here that they had some stringent criteria for including the studies about duration, about the type of intermittent fasting, as much as they could actually. So you have 6 months, you have 12 weeks, and various kinds of energy restrictions, and various groups were there, which I will not go into the details for lack of time. But you can see that there are different kinds of studies over here, and you can see everywhere that weight reduced, fat mass reduced, and lipids were quite okay. So this is again the same review which tells you all the different studies. And here also you can see that some of the studies have got lipid profiles, which I'll go into that a little more in details. Leptin, some studies have talked about ghrelin, leptin, adiponectin, etc., etc. And these are again some more studies. So there are many studies between 2003 and 2018. We don't have a lot of participants, but collectively this review tells us a lot about all these things. So this is 12 weeks, 3 months, 8 weeks, 24 weeks. There's a follow-up in this. Some have studied also the quality of life, and some have studied things like depression and neurosis as well. So some of these differences are significant, some are not significant. I would like to now take you to specific things such as intermittent fasting in cardiovascular disorders, and this is an overview of that. And you can see again that the number enrolled may be small, although in some you have 100 or 77, and there is a variable time period also, and this is the participant description. And what did we find in this? What you find in this is the impact of intermittent fasting on blood pressure. And you can see that in many of them, the p-value is significant, 12 weeks, 6 months even. And you can see that both the systolic and diastolic blood pressure have reduced. So this is as far as the blood pressure is concerned. What about the inflammatory markers? You can see here that CRP, leptin have reduced in some are significant, some are not significant. And you can see that in some, the adiponectin has increased, again, significant. And you have interleukin 6 and TNF alpha, some significant, some not significant. So just as it was suggested right in the beginning, that there is a hypothesis that the inflammatory markers might go down, oxidative stress might go down, and you can get a favorable metabolic profile. So these smaller studies do pan out and show us that there is at least a hint that these things do indeed happen. I'm sure we need more studies, but it is something that is worth exploring. This is a case, very interesting case series of 3 patients where they've used therapeutic intermittent fasting for people with type 2 diabetes as an alternative to insulin. And these are the 3 patients between 40 to 67 years of age. This is the age of the years with diabetes, 20 years, 25 years, and 10 years, which is very impressive, because at 20 and 25 years, when somebody needs insulin and you do a manipulation, a dietary manipulation as an alternative to insulin, and that is what this is going to tell you. These were the comorbidities of these 3 patients, and this was the different kinds of fasting that they were on, 3 times a week, these first two patients, and alternate days for 11 months for the third patients. And what did they study? They studied the time to discontinuation of insulin, the fasting glucose, A1C, weight, and the waist circumference. This is what they studied. And what did you find? This is the results of patient 1, patient 2, and patient 3. And you can see here that A1C reduced from 11 to 7, 7.2 to 6, and 6.8 to 6.2 respectively in the 3 patients. These were the initial diabetic medications, as you can see here. And in the final diabetic medication, at the end of the fasting, intermittent fasting period or the process, you can see that 2 of the patients went off medication and 1 of them went off insulin and came down to only 1 drug. The weight loss also was pretty good, from 83 to 73, 61 to 50, 97 to 88. And the waist circumference also decreased. And the time that they took to come off insulin was 5 days, 18 days, and 13 days. This seems pretty impressive. I know it is only a case series, but we have to start somewhere, and this is some of that. So effects of intermittent fasting on body composition has also been seen in this. This is a review again, mind you. And in this review, they included alternating day fasting trials of 3 to 12 weeks in duration, and they showed that it was effective in reducing body weight, body fat, total cholesterol, triglycerides in both normal weight, overweight, and obese humans. And whole day fasting trials lasting 12 to 24 weeks also reduced body weight and favorably improved the lipids. So this is what has been shown in this particular review, and they included quite a lot of studies. Now, I'm going to show you one case from my data, just a single case. This is a 56-year-old male known diabetic for 2 years without hypertension and a very sedentary lifestyle. He was euthyroid but sleepy all the time. And his weight at starting was 122 kgs with a BMI of 37. And he was on metformin 1500 milligrams per day in total. So we put the patient on intermittent fasting and added a VLCD to it during the eating period, and metformin of just 500 milligrams instead of 1500. In the very first week, even that 500 milligram of metformin could be withdrawn. And this was the weight reduction that you can see, because there was both intermittent fasting as well as a VLCD. And he came down to something like 112 at the end of just a month and a half. And you can see here that the fasting came down, the postprandial came down, and the weight is again also seen here, as did the BMI. So this patient was on intermittent fasting. Then came this very important study just in September of this year on effects of time-restricted eating on weight loss and other metabolic parameters in women and men with overweight and obesity, called the TREAT randomized clinical trial. So the interventions were that there was one group which had consistent meal timing, instructed to eat as usual 3 times a day, whereas the other group of time-restricted eating was instructed to eat ad libitum from 12 p.m. until 8 p.m. and abstain from caloric intake from 8 p.m. until 12 p.m. the following day. So this was a typical 16-8 intermittent fasting regimen, and it was a 12-week randomized clinical trial with a BMI
Sorry to interrupt, Dr. Neeta. If another 2 minutes, please.
Yes, I'll be ending over here.
Thank you.
So the conclusions and relevance of this study was that time-restricted eating in the absence of other intervention is not more effective in weight loss than eating throughout the day. But importantly, the study also showed that there was a hint towards reduction in lean muscle mass, which is not very good. So this study tells us that intermittent fasting may be beneficial in some ways, but it is important to pay attention to the lean mass, perhaps by introducing resistance training and increasing the protein intake. So to conclude, when it is taken up for health reasons in patients with diabetes, it has been shown to induce weight loss and reduce insulin requirements. Medical guidelines are non-existent. Medically supervised therapeutic fasting regimens can help reverse type 2 diabetes, as I showed you. It is an underutilized dietary intervention, in my opinion, because of lack of data, because fasting is actually a very practical dietary strategy. And long-term benefits on CV risk remain to be fully studied, though I've shown you a meta-analysis of the same thing. When done under the supervision of the patient's healthcare provider and with appropriate personal monitoring, it could probably be safely undertaken, but future studies are very important, and combining it with exercise, especially resistance training, becomes very, very important. I'm sorry about that.
Yeah, Vinny.
Yeah, this is my last slide. And oops. Okay, so I conclude my talk by saying that much remains to be investigated. It is perhaps a good strategy, but it needs tweaking, and we need more data, no doubt. But we need to do it in such a way that we tweak the intermittent fasting to be combined with resistance training and pay a lot of attention to the protein part of it. So I end by saying that intermittent fasting may be good for metabolism. There is a hint that it may be good for oxidative stress and as an anti-aging tool, as we've seen in some Japanese communities who do this kind of fasting and who eat very, very little. So thank you very much.
Atul?
Yes, sir. Thank you, Dr. Neeta. We really enjoyed your lecture. I have a very elementary question related to time-restricted eating. And in fact, this question was asked by one of the patients. He says, you telling me to eat within a time frame of 8 hours, but you tell me to space my medication 12 hours apart. So how do I manage that?
Well,
so a lot of our patients on BID schedules, both with OADs, premix insulins. So we tell them take it at 8 a.m. and 8 p.m. So he says, how do I manage medication with your recommendation of time-restricted eating?
Yes, that's a very nice question, sir. Since we have no guidelines, we actually have to do this on an ad hoc basis. And what I personally do if I put my patient on intermittent fasting is I try to make sure that there are no secretagogues that the patient takes, like sulfonylureas. A secretagogue such as a meglitinide works very well, but not sulfonylureas because they're long acting. Secondly, if it is insulin, we would have to use insulins which are in tandem with the eating pattern of the person. So a very flat profile insulin, such as a truly long acting one, such as maybe Digludec, can be useful if the patient absolutely needs insulin. And the prandial insulin is given only with the two main meals of the day. So that would be if it is a 16-8, it is typically breakfast and dinner, then that is what we would do. And then you would try to use drugs that do not cause hypoglycemia, such as SGLT2 inhibitors or perhaps DPP4 inhibitors, and of course there's metformin. So it has to be managed in that way. And of course, self-monitoring of blood glucose becomes very, very important for these patients. And that is why I said that it has to be done under close supervision, at least until the patient is off the secretagogues or perhaps off the insulin.
Thank you very much. Thank you.
Atul, thank you so much for conducting this session so well on time. And Neeta, I must say that you balanced this presentation very well. Often, if the topic is given, a person speaks for that topic endlessly and not against the topic. And you have balanced this topic so well that people for and against can both understand, and both are for you. So everybody is for your presentation. Thank you for wonderful presentation.
Thank you, sir. Thank you so much. Thanks for having me.
Ritesh, is Alka going to conduct?
Yeah, sir. So Alka has some issues with the net, so I will introduce the next speaker. Yeah. Yeah. So we go on with the next session, which is for that I will invite Dr. Munashish Sahu, who's a friend and a consultant endocrinologist at Dr. Sahu's Hormone Care Center, New Delhi, and Vimhans, New Delhi. He has earlier been a part of this symposium, and it's my pleasure to welcome Dr. Sahu. And he'll be giving his opinion on current evidence with glycoside. Over to Dr. Sahu.
Thank you, Dr. Ritesh. I hope audible and slide is visible. I will roll on. And it's always a pleasure to get associated with, and there's always this time-bound management, which I am absolutely impressed with the entire group of OTC doc. The topic that has been interested to me is just to show the current evidences that is available with glycoside. What I will be doing is to take you through in terms of what helps in the clinical decision making is about a new analysis of any landmark study, any new clinical trial data, and if that should lead on to a logical question of any recent perspectives from the basic pharmacology that should help in the clinical decision making. Landmark study that we are all aware about is the ADVANCE study. And if we need to discuss about the landmark study, we need to always keep in mind that this is a landmark study which stands in the same bucket of, let's say, UKPDS, the ACCORD trial, and this has been quoted time and again at various platforms. What we need to remind ourselves is that the intensive arm had only one specific sulfonylurea, and that is the glycoside modified release. So therefore, this needs to keep we need to put this in context. The median duration of the trial was for 5 years, and the total median follow-up, which is the ADVANCE on, was roughly to around 10 years. Key data point, as on the left side, as we can see, that with the glycoside extended release, the HbA1c that was attained was to around 6.5%, which is the one kind of an HbA1c that all of us try to achieve for our patients. When we are talking about the macrovascular outcomes, the macrovascular outcome was nothing different. And that is actually a good thing, because when we talk, we need to keep things into context, because in the era of SGLT2 inhibitors and the GLP-1, we are always talking about the CV safety. We need to be absolutely unambiguously clear that all the sulfonylureas, especially the third generation, like glimepiride and glycoside, are CV safe. There is no unsafe signals out there. What is important to understand, with context again to glycoside, with context to ADVANCE, on the left panel of the diagram that is given, at 5 years of follow-up, there was approximately 65% risk reduction of an ESRD. On a follow-up of over a period of another 10 years, this legacy effect was maintained. So almost like 46% risk reduction of ESRD. When we are talking about albuminuria, the most important aspect of nephropathy, there was almost a 20% reversal. So these are all old data. We need to keep things in context. There is a new analysis which was published in 2020, again of a reanalysis of ADVANCE, pretty much the same information what we learned from ADVANCE. So this is a very key thing which we need to put things into context with sulfonylurea and glycoside. And we are talking about evidences. What are more recent evidences? I'll go through some of the slides. This 2020 was a publication of another very decent, elegant article, which I must say, it was a real world analysis. The data that was taken was from the UK database. And the caption of the article tells everything, that this was a comparative effectiveness of glycoside modified release versus sitagliptin as a second line treatment, which means into the database. They looked around right from 2010, an observational period of around 9 years. And they were like new users of glycoside modified release or a sitagliptin once the metformin had failed. So this is what we practice. Once something fails, we go on. And how do you decide upon which one to choose? The endpoint which they tried to analyze, after doing a very good propensity scoring, that means the baseline were matched to both the arms being glycoside as well as a sitagliptin. The primary outcome is a time to HbA1c less than 7%. Now, this is something different. We typically talk about trials and we just analyze only about just an HbA1c. What is the end value of an HbA1c among two arms? This is a time to HbA1c, and I was not surprised with this because one of the lead author is Professor Khunti, and among many publications, what has been told by various authors, including them, is the fact that in the first 1 year of treatment, if you are able to maintain a very good HbA1c, it has a legacy effect. So this is important and critical to understand the primary outcome, which is slightly different from others. The time to HbA1c of less than 7%, as is seen in the graph, on the y-axis is nothing but a probability curve. So what is the probability of achieving an HbA1c of less than 7%? Two important messages. One message is that on the red bar, that is the glycoside, it attains a faster control to an HbA1c, which is maintained. And in both the arms is a lesson, whether it is less than 6.5 or less than 7, is a lesson that whatever control is achieved, it typically happens in the first 1 year of therapy. And that is very critical because we know that type 2 diabetes mellitus is a progressive disease. So the take-home message once again is that time to achieve the HbA1c, which is definitely impressive with glycoside as compared to sitagliptin. We're always fascinated with the word of durability, which came up with glitazones, then with DPP4 inhibitors. Now, just a very important context here, in that almost 9 years of an observational data, very elegant data, is the fact that there was a median durability which was similar, both for sitagliptin as well as glycoside. Now, this is important again when we talk about hypoglycemia, although numerically higher, but the severe hypoglycemia, significant hypoglycemia, was almost similar. Take-home message out here is that glycoside extended release was more effective than sitagliptin in terms of reducing the HbA1c, the time to HbA1c, and with a similar durability. Now, this again needs to put into context because generally we have a notion that using a sulfonylurea would lead to less durability, but this is one of the real-world evidence published recently, almost 9 years of data. It's a very elegant data to suggest that the durability was similar. The third context, when we talk about, I just floated from a kind of an advanced study, ESRD, to a very recently published RWE analysis, durability was similar. What about hypoglycemia with sulfonylureas? And now let me talk about glycoside only with the context. The best way to look around for hypoglycemia, and I'm just taking a clue from the intermittent fasting topic, which was preceding me. And one of the questions that came up was that, which is the OAD and can we give an OAD in a safe note? So let's look around at a hypoglycemia in some of the Ramadan trials, quoting around 2 articles. 2011 was a publication where there were 2 arms in the setting of Ramadan. One arm was sitagliptin, the other one was various sulfonylureas. What the graph and the bar depicts is that what is the hypoglycemia rates with sulfonylureas, glibenclamide, glimepiride, and glycoside versus sitagliptin. Key take-home message out here is that almost the same with glycoside as compared with sitagliptin, which means there are some agents which would be safe enough. Let's now look around something which got published this year itself, 2020. Sheila Sheikh from India is one of the lead author. And this was a real-world study. It was a prospective study. Individuals who were on glycoside, almost 60 milligram per day, and they were at least taking glycoside for 90 days before enrolling themselves into the study. They were looked around the pre-Ramadan period, Ramadan period where the fasting really goes on to around 15 hours or so, and then the post-Ramadan period. A busy slide, but I will just read out the salient points. Number one, the investigations, they actually continued with glycoside extended release. More than 95% were more than 60 milligram per day. The glycoside, what it was done was that it was given around the main meal, which was around the iftar. It is a very logical choice. There was no dose dependency on the serious adverse events. No patients reported any severe documented hypoglycemia events. And if we look around just the numbers with glycoside related to hypoglycemia is almost very, very low to what we have been documented even with DPP4 inhibitors. That therefore leads to a question that is glycoside behaving something differently with context to hypoglycemia. One of the first study, which was a European study, the GUIDE study, it compared glimepiride with glycoside when it started entering, and everybody was interested to understand how the agents in the same class of sulfonylurea behave differently. Hypoglycemia was lower. So time and again, across a lot of board groups, whether we talk about a head-to-head comparison, whether one talks about the advance, whether hypoglycemia was definitely lesser as compared to the accord, whether one talks about Ramadan study, somehow the role of hypoglycemia with context to sulfonylureas, and especially right now with specifics of glycoside, is not so unimpressive. It's pretty impressive to state that the hypoglycemia is lesser. Is there a pharmacological basis therefore? And that's the only question that we need to ask ourselves. Well, if we look around the glycoside, there is no benzamide moiety. So there is a reversible in terms of an interaction with the SURN receptors. And it is very specific to the pancreatic SU1 receptors. And the lower panel of the bar, it just gives a glimpse that across various channels, some of the channels are not touched about with glycoside, with the EPAC channel, etc. So leading on to some logical questions that perhaps the hypoglycemia with glycoside that is being observed across various clinical trials, clinical observation, may have a bearing with the delicate pharmacology based on glycoside. Just 2 slides of CV evidences. Well, not much of CV evidence is beyond advance, but again, a published article of 2020, it was kind of a meta-analysis of various meta-analysis. Overall, if we talk about the CV death with glycoside, this was definitely lesser as compared to the other sulfonylureas. There will be no other head-to-head comparative trial, but some meta-analysis which should show us the way. So perhaps the class concern does not find an evidence with glycoside, where it does have a lesser hypoglycemia with the efficacy that is proven as seen with advance, even with the context of ESRD, has been found to be durable, as was seen with the real-world evidence study and with microvascular endpoint. The final 2 slides is that what are the key messages? And here in terms of the messages is that when we talked about the landmark study, we need to remind ourselves, not only was the study of advance went on for 5 years with glycoside in the intensive arm, the follow-up period was for around 10 years. The impressive aspects of ESRD stands established with the advanced study. Any new clinical trial data to what from Professor Kunti was the fact of the UK database, and 9 years, more than 9 years of observation of glycoside being compared with sitagliptin. The extended release was more effective than sitagliptin with the time to HbA1c and with a similar durability. With a hypoglycemia, which was at par. Numerically, it was higher, but it is but obvious with any sulfonylureas. With context to hypoglycemia and the intermittent fasting and hypoglycemia in the setting of a Ramadan, now there are trials, now there are evidences. And in one of the first real-world study which got published this year itself, it definitely shows that even with glycoside, which was used to more than 60 milligram per day, given during the time of the main meal, that was the iftar, and without any dose adjustment, there was not, most patients can actually fast very safely. And this may find true with relevance to the basic pharmacology, perhaps because glycoside only acts on the SUR1, was very specific to pancreas and in a reversible fashion. And now as one is really learning, the EPAC, which is associated with SUR1, is not so heavily impacted with glycoside. On that note, thank you very much.
Thank you, Dr. Sahu. That was very clear as always, very evidence-based as the topic was, and very well presented. If there are any questions, people will type in the chat box, and you are requested to answer them as they come. So, thank you, Dr. Sahu. So we'll move on to the next session. Thank you. So we move on to the next session, and I have the pleasure and honor of inviting Dr. Praveen Chandra, who's the chairman of Interventional Cardiology at Medanta, the Medicity, Gurgaon. He's recognized as one of the leaders in angioplasty in the country and is proficient in a lot of new devices and technologies. And today, he will be talking about heart failure and diabetes, a deadly duo. So welcome, Dr. Praveen Chandra.
Good morning to all of you, Dr. Ritesh, and thanks to Dr. Anup Mishra and all of you there sitting there for giving me this opportunity to share some insights into the cardio-diabetes arena, which we call it as almost a new specialty. So today my topic is heart failure and diabetes, and as I saw that it is a Ahuja Bajaj Symposium, so before I start my presentation, I must pay my tributes to the leading, these pioneers from the field of medicine in India who established the endocrine metabolism and, brought new understanding to all of us. Of course, I was not their student, but I certainly gained a lot of knowledge from his, students, especially Dr. Anup Mishra and others. So I must say I have some reflected knowledge from these individuals about cardio-diabetes. And as you know, that medicine included everything in medicine, cardiology, diabetes, everything. And now we are seeing this is happening again that the cardiologist and diabetologist are coming together. So you are seeing me on this primarily a diabetes program, and I know today. So, friends, heart failure and diabetes is a seriously bad combination, and I call them bad cousins. They come, and as you all know in life, bad things come together and they just try to make things even worse at times. So what is the situation now? What is the worldwide situation of diabetes? And as you can see here, that in chronic heart failure, these patients who have in diabetic patients, almost 25% are in chronic heart failure, 40% develop acute heart failure. So which means that there is some kind of a pathogenetic mechanism here in patients with diabetes who go on to develop heart failure. So today I'm going to just present to you the link between the diabetes and occurrence of heart failure. Then of course, how do we manage these kind of combined situation? And the new drug, of course, not very new, sacubitril valsartan in patients who have heart failure and diabetes. So looking at the global situation, as you all know, I don't have to tell you all because you are the expert in diabetes sitting here. And the prevalence of diabetes and pre-diabetes is increasing tremendously. And at the same time, heart failure is now joining them as bad friends. And as you can see here in the last 15 years, the incidence and prevalence has gone up tremendously. And heart failure is the second frequent reason for initial clinical presentation for cardiovascular diseases. So, and of course, many of these patients are diabetics. So apart from stable angina and non-fatal MI, heart failure becomes more frequent and which is more difficult to treat and has more morbidity and mortality. So we cannot kind of undermine this situation, and we have such a huge population of diabetic patients. Now, diabetes, as you can see here, what happens is it's not just a bystander, rather an unwanted path leading to heart failure. So you can see what are the various mechanisms: RAS activation, cardiomyocyte hypertrophy, inflammation, dyslipidemia, endothelial dysfunction, calcium handling, autonomic dysfunction, all leading to heart failure eventually, whether it is a ischemic pathway or a non-ischemic pathway. Now, these are the various risk factors. So you have more risk factors, you have more occurrence of heart failure in diabetic patients, as you can see here. So the more they have, hyperglycemia, they more have, advanced stage, they are, hypertensive, they are obese, and of course, diabetes leads to more occurrence of renal and cardiac. So this cardio-diabeto-renal axis is a really bad axis. I must say the deadly trio is really bad. And of course, we have to treat them very, very carefully. So you can see in various studies which were done in prevalence of diabetes and heart failure and with reduced ejection fraction and prevalence of heart failure in diabetics, you see it's like quite a significant number of patients who were treated in these trials. As you can see here with various drugs, and these are the DPP-4 drugs, the SGLT2 inhibitors, the GLP-1 agonists, which I'll briefly touch upon in a little while. So the coexistence has a strong impact on clinical management and prognosis. And in these patients, the cardiovascular outcomes are really affected. And look at this, the effect on the cardiovascular outcomes. And this is increased CV mortality in heart failure patients who have diabetes in various studies, as you can see here. And of course, increased incidence of hospitalization with heart failure in patients who have concomitant diabetes. It's 1 to 1.9 times the occurrence of hospitalization. Then excess rates of hospitalization and concomitant heart failure in dedicated diabetes trials. These are the diabetes trials. You see, more and more patients are getting affected for hospitalization. And if you go over a period of time, from 1 year to more, prolonged period of time, they have increased risk of cardiovascular death, 7% increased risk, and 27% increase in risk of heart failure hospitalization at 1 year. And the long-term mortality is approximately 50%, which means half of the patients will be dead if they have heart failure and diabetes. So heart failure, we cannot forget. We have to treat these patients much, much more effectively and safely so that we can save these very, very difficult patients. So early diagnosis and immediate treatment is important, and we have to detect these patients who come with very, kind of atypical symptoms. Many times these diabetic patients who have stable CAD, they come with shortness of breath, and we just sometimes overlook these patients, but actually they are very sick patients. And when we start looking at their ejection fraction, once the ejection fraction starts going down, that is the starting point when we have to start managing these patients early with appropriate treatment. Now, the question is, what are the treatment options in these patients in heart failure and diabetes? So these are the, all these drugs which you all as cardiologists and diabetologists know: ACE inhibitors, ARBs, beta blockers, the aldosterone antagonists, and now the ARNI, which is there. So I'm going to discuss a little bit about them, and of course the diabetic drugs. So I'll have a quick summary of that. So what is the situation now of anti-diabetic drugs and cardiovascular outcomes? Where did it all start? I think starting point was that the glitazone studies, which started throwing so much light on that they are harmful for these patients, and they go on to develop heart failure. So what are the safe drugs and what are the unsafe drugs? You can see here now the more safety of anti-diabetic drugs and in fact benefits have recently been shown with the SGLT2 inhibitors, and now with a new study which was presented in the AHA, the SGLT2, SGLT1 inhibition, the GLP-1 receptor antagonist, the liraglutide and the semaglutide, and metformin, which has also brought to be in the safe category since 2016. Up to 2016, it was unsafe, but now it has been found to be safe, especially in patients who are having renal, normal renal functions or mildly deranged renal function. In severe renal dysfunction, again, metformin is not the drug of choice, not so safe. And DPP4 inhibitors, there also a lot of discussion has started happening. And as a group, we cannot recommend, but certainly Lipton has showed in the TCOS trial that it was reasonably okay. At the most, I must say that at least it was neutral. And unsafe drugs, you already know, the sulfonylureas, the TZDs, and of course, to a certain extent, the insulins. But what is the situation of heart failure therapy in patients with diabetes? There are no clinical trials of heart failure treatment which are conducted exclusively in patients with diabetes. So you see, the problem is so much, we still do not have that kind of, but certainly there are so many studies which have been done and so much patients are there, diabetic patients, in these studies that we can make a reasonable conclusion. And these were the guidelines which were there up to 2016. There was no specific constraint to heart failure treatment in diabetic patients for management of heart failure. And in fact, most of the therapies were similarly effective, whether or not patients had diabetes. So that was the situation, but now the situation is changing a little bit. So all were found to be similar vis-a-vis glucose control also. Beta blockers, ACE inhibitors, MRA, ivabradine, and now the ARNI sacubitril valsartan combination. So these are some of the limitations, some minor limitations, I will say, not major limitations, because they do not preclude the use of any of these agents in diabetic patients. For example, in beta blockers, initially people had a lot of reservation many years back, I must say, not now, that they mask the symptoms of hypoglycemia, they influence lipid profile, but still beta blockers are one of the main pillars. So these are the main pillars of treatment of heart failure in patients who have diabetes or do not have diabetes. So what do we need now? So we need a drug, anti-diabetic drug, which improves heart failure situation, and we have some data on that. And we must have drugs, heart failure drugs, which should not increase the dysglycemia and in fact lead to better outcomes. So this is a new drug, which is the neprilysin, has been there in the commercial use now for the last maybe 2 years now, and a lot of experience and evidence has already accumulated for the use of this drug. So this is the basically the effect of this combination of sacubitril valsartan on neuroendocrine balance, and as you can see here, that it leads to more vasodilatation and diuresis. And here with the valsartan beta blocker combination, it was little worse, but now it has shown improvement in terms of vasodilatation and diuresis compared to vasoconstriction and water retention with with the beta blocker combination. So it makes a balance with that. Now, it has shown superior outcomes over enalapril in the clinical endpoints in these patients. And you can see there is a reduction in composite outcomes, deaths, hospitalization, and all-cause mortality if sacubitril/valsartan as combination is given in comparison to enalapril. And in diabetic patients, how does it help? So in diabetic patients, it works at various levels. It increases the insulin sensitivity through increased natriuretic peptides, increased bradykinin, and it has a increased GLP-1 effect leading to anti-hyperglycemic effects. And as you can see here, decreases DPP-4 activity, so increases beta cell activation. So this is an additional effect of this drug on in patients who also have diabetes. So those patients of HFrEF and those who have diabetes will have this mechanistic advantage when this drug is given to these patients. So where has this drug been studied? So this is the biggest study which was done using in this trial. This is the Paradigm HF trial. And here they compared the effect of this drug in compared to enalapril according to the glycemic status. And also it was investigated to see whether the HbA1c effect and the initiation of insulin or other oral anti-hypoglycemic drugs if got affected with this therapy or not. So look at this results. It impacts CV outcomes in HFrEF is irrespective of glycemic status. So if a patient is diabetic, it helps. If the patient, even if he is pre-diabetic, it helps. So we can safely give this drug to improve outcomes and decrease the risk of cardiovascular death in these patients. Looking at heart failure hospitalization, again, this trial showed that it is very effective. In fact, it does lead to positive outcomes in patients who have diabetes, who have undiagnosed diabetes, who have pre-diabetes, and those patients, of course, who do not have diabetes also get affected and show advantage. Quality of life improves with these drugs within 8 months, and decrease in HbA1c was found to be persistent and significantly greater in patients receiving sacubitril/valsartan over 3 years of time. And the HbA1c, even if it was more than 8 or less than 8, it led to reduction in HbA1c over a 1 year period of time. Impact of insulin initiation was also affected, 29% reduction in new use of insulin in patients who were on this sacubitril combination. And it provided better tolerability as compared to enalapril with regard to renal safety. So there also, as you can see, up to the level of 2.5 creatinine was not a major issue. And the slower rate of decline in GFR was seen when these patients were on sacubitril/valsartan combination. So to summarize, I think we can safely say that hyperglycemia, insulin resistance, hyperinsulinemia in diabetes mellitus trigger a cascade of deleterious effects that actually leads to heart failure. So these are the plausible mechanisms. And heart failure and diabetes are super bad combination. They increase the risk of morbidity, mortality, and as of now, we know that we are still overlooking many of these patients, which we have to very carefully start treating them with much more care. So there are no specific constraints to heart failure treatment in diabetes. It's not that one of these drugs cannot be given. The heart failure drugs, as I showed you, those 5 pillars of heart failure treatment, but certainly a heart failure therapy that is protective against incident diabetes or worsening control is a drug combination. Sacubitril/valsartan improves clinical outcomes, improves glycemic control in HFrEF, which is heart failure reduced ejection fraction patients with diabetes mellitus. Thank you very much.
Thank you, Dr. Chandra. That was a very lucid presentation, well finished, well in time, and it was a very good summary of the evidence on sacubitril/valsartan, especially in patients with diabetes. I'm sure there would be some questions. The audience is requested to type them in the chat box, and Dr. Chandra, if you will be kind enough to answer them as the questions come. In the meantime, we'll proceed with the next agenda. So thank you, Dr. Chandra.
Thank you.
So we move on to the next agenda, which is the quiz. We had a quiz yesterday. 2 questions yesterday, and now we have another second part of the quiz, both on diet and diabetes. So we'll have 3 questions, and the audience is requested to click on the icon of polls below their screen, and then they can just click on the correct option. There'll be 3 questions each with 4 options each, and then you have to click on the correct option. So Mr. Darshan, please start the quiz.
This is the first question of the key.
Yeah, so this is the first question today, or the second question of diet. Which of the following amino acids has the maximum effect on stimulating protein synthesis? And the options are A. tryptophan, B. lysine, C. valine, and D. arginine. Please click on the right option.
Please 20 seconds. So can we move on the next question? Hello, Ritesh sir. Can we move on to the next question?
Well, just a second. So has everybody answered? Have you got the results? Yeah. So you can tell me later, but you have got the responses.
Yes.
Okay. So I'll tell the correct answer now. The correct answer is valine. So valine is a branch chain amino acid. So valine, isovaline, and leucine. Dr. Naval yesterday talked about leucine in sarcopenia. So leucine, of course, is very important, but also valine and isovaline are also very important in stimulating protein synthesis, especially in patients with sarcopenia. Yeah, please move on to the next question. Yeah. Which of the following drugs has a high potential to cause diabetes? Is it fluoxetine, rituximab, cisplatin, or alpelisib?
Have you finished, Darshan?
Sir, 10 more seconds.
Okay.
Okay, so this was covered today only by Dr. Sandeep Tak very well, and the correct answer is alpelisib, which is a cancer drug used in breast cancer. It has a high potential to cause very high sugars, and this was discussed very well in the morning. We move on to the next question. Which of the following has not been shown to cause reduction in severity in COVID-19? Acarbose, metformin, sitagliptin, or statins?
Should we end, sir?
Yeah. So the correct answer is acarbose. This was also discussed yesterday by Dr. A.K. Singh. Metformin has been shown to reduce mortality. We have studies with sitagliptin also, And statins also have been shown to reduce symptoms and severity in COVID-19. So the correct answer is acarbose. So this was the quiz. We'll announce the winners in some time, maybe after an hour or so. And now we move on to the next session, which is, and for that, I would invite Dr. Atul Luthra, who's the additional director at Fortis CDoc at Fortis Memorial Research Institute, Gurgaon. He's an excellent orator. He's part of the organizing committee, and he'll be talking on newer basal insulin's potential for control of time in range.
Just give me a minute. Tell me when my slides are.
Yeah, they're visible. Yeah.
So somehow in this symposium, besides nutrition, time in range is the most spoken about topic. And I will be specifically focusing on the relevance of time in range in relation to second generation basal insulins. So this is the overview of my presentation. TIR, I will just go through because we have talked about it enough. Global recommendations and how do we address this TIR in the context of second generation basal insulin. So we know that the tripod of glycemia is fasting, prandial, and A1C. So we used to talk of the glycemic triad, but thereafter we have started talking more about the hypoglycemia and weight gain with the oral therapies, glycemic variability, and better quality of life. So we have now rather a hexagon where glycemic variability, quality of life is given equal importance. So from triad to the hexad, glycemic variability is a big contributor, which has both two components, the spike as well as the trough, the peaks and the lows. So it refers to fluctuations in the blood glucose levels. Dr. Amrita has spoken about it yesterday, within the day or day-to-day, inter-day, and it leads to both high glucose levels as well as risk of hypoglycemia. And for comprehensive glycemic control, we need to cover both the peaks and troughs, try to have a smooth and flat glycemic curve rather than wide excursions. And so A1C has its limitation because it tells us only about a retrospective levels of glycemia, and variability is not captured by this parameter. And A1C, whether it is a smooth control or cancellation of spikes and troughs with each other, it does not tell us what the inter-day and the intraday variation is. And therefore, we have now, as Dr. Amrita elegantly showed, that there are ways like CGMS and your glucose monitoring, ambulatory profiles, and time in range. I will not stop on this slide because it has been talked. 70 to 180 is the most recommended target, except in certain situations like gestational diabetes or the very elderly. Because in elderly, we can be a little lax, and in gestational diabetes, we are very strict. So we know that TIR is recommended to be kept below at least 70 or more because it is a marker of complications. So this is one sample report of a CGMS summary and an ambulatory glucose profile, which gives us actionable data to implement therapeutic strategies in the individual care of patients to improve their outcomes. So we have several recommendations by the Advanced technology and so on. So actually, I'll just like to highlight this particular fact that only a few weeks before the ADA 2020 publication, which generally comes up in the month of January. So around this time last year, there was a supplement to ADA 2019, which was published in January, and showed that this time and range needs to be equally given importance, and it should be additionally used as a metric for a good glycemic control. And the American associations have also recommended that glucose monitoring with CGM is a preferred mode. So coming to what I am supposed to talk about is the how do we address the time in range with second generation basal insulins? Because we know it is TIR is important, but in resource sensitive settings, it may not always be feasible. And so we need to make our own treatment solutions. Even if we are not able to continuously monitor glucose levels, can we address glycemic variability with basal insulins? So we know that basal insulins are an important part in the therapeutic arsenal of type 2 diabetes, especially when the glucose gets out of range. And generally, when we start with one insulin, it is a basal insulin at night. And the beauty of this therapeutic strategy is that it brings down the entire glycemic profile, and you start your day with a good fasting blood glucose, and these prandial spikes automatically come down. So this is a very important strategy, and the basal insulins take care of the peaks, especially caused by the prandial state, and also because they have a very low incidence of hypoglycemia in the interprandial period, the troughs really, there is much less incidence, like from having moved on from NPH insulin to glargine insulin, there was a much lesser risk of hypoglycemia. And now we have the second generation basal insulins, which I will allude to. So let us examine how second generation basal insulins will address glycemic variability and help people to be in the TIR of over 70% without actually resorting to a ambulatory profile or a continuous monitoring system. So this is a euglycemic clamp study which showed low glycemic variability with glargine U300. So we can actually divide the basal insulins to the oldest one as NPH, and then came the Levemir and the U100 glargine, and the latest second generation is the glargine U300 and the Digludec or IDEC 100. And of course, we heard that we are coming up with maybe in a year or so with a once a week basal insulin. So basal insulin is a strategy which is commonly used. So this clamp study in particular showed that the within day variability was significantly lower with glargine U300 versus Digludec 100 at a dose of 0.4 units per kg per day. So this is another small elegant study to compare the efficacy and safety of glargine U300 versus Degludec and using CGM, and the mean percentage of time in range was markedly below for U300 glargine versus the comparator, and the incidence of hypoglycemia and nocturnal hypoglycemia was markedly lower, and it was seen that this strategy is associated with a good time in range target. So another study, using flash glucose monitoring, which is more often used, TIR of glargine U300 versus IDEC 100, and the efficacy endpoint was used as time in range. And as we can see, that there was a lower incidence of nocturnal hypoglycemia with glargine 300 compared to degludec. So this is a relatively recent publication, which is looked at the efficacy and safety of these two second-generation basal insulins in adults with type 1 diabetes in routine clinical practice. So this is actually the first real-world evidence. This was the study design of this particular trial, and the switchover strategy was used, and the time in range profile of glargine U300 and IDEC was compared. So the differences again favored the glargine U300 over degludec in this setting. So one care study was the first real world setting of adult type 1 diabetes. And in those who were switched over from the first generation basal insulin, and more people in glargine 300 remained in the TIR at night versus degludec. So the key messages from this particular look at the time in range glycemic variability and second generation basal insulin, that there is increased risk of hypoglycemia and complications with high spikes, but hypoglycemia is equally important. TIR is important to measure, but yet in our resource sensitive settings, seldom measured, and it is recommended to go for treatment solutions which will take care of TIR, even if we do not use an ambulatory profiling or a continuous glucose monitoring system. And second generation basal insulins demonstrate improved glycemic variability other than previous regimens. And among the second generation basal insulins, glargine U300 has demonstrated lesser nocturnal hypoglycemia or severe hypoglycemia during the titration period, and also demonstrated a better time in range profile. Thank you very much. And I am open to any question if there may arise.
Thank you, Dr. Luthra. That was very well presented and very well finished in time. So, if there are any questions, the audience is requested to type in the chat box. And we'll move on to the next session. And it's my pleasure to invite Dr. Renal Jayawardene, who is a professor of nutrition at the Department of Physiology, Faculty of Medicine, University of Colombo, and a visiting fellow to the Queensland University of Technology, Australia. And he has a vast area of research experience, which includes several multinational clinical trials, epidemiological surveys, case control studies, reviews, meta-analyses, and he has published widely. His work has been cited widely, and he has recently published a systemic review on the effect of coconut oil on cardiometabolic risk. And this is the topic he's going to elaborate on today. So welcome, Dr. Renal. Over to you.
I'll just add to that, Ritesh, that Renal is one of the youngest professors in the University of Colombo, and that's because of his very, very prolific research. So Renal, welcome. Renal, are you there?
Yes, sir. Thank you. Thank you very much for your kind word. Yeah.
Dr. Renal, you can open your video also, please.
Yes, I will. It's not possible. Hosted stop it. Can you see my slides now?
Yeah, we can see your slides now. Yeah.
Okay. And good afternoon, everyone. And I must thank for Professor Mishra and the organizing committee for inviting me for this prestigious symposium. I'm very much honored to discuss about this health effect of coconut oil. This topic is actually beyond cardiometabolic risk factors also. But first of all, I must declare some conflict of interest. I don't have any association with the pharmaceutical or drug company, or especially for the coconut industry. But I have been eating coconut for the rest of, from the birth. So last 40 years, I have been eating coconut. So that's the main conflict of interest with the coconut with me. And in this presentation, I will discuss the chemistry of the coconut oil, because it's believed the chemical structure of the coconut oil is quite unique and which may have different health benefits. Nowadays, there are several types of coconut oil also emerge in the market, like virgin coconut oil, so on. So secondly, I'll discuss about a different type of coconut oil, whether they are really different by composition or by ingredients. And later on, I'll discuss about what are the mechanism or molecular mechanism behind this coconut oil on several health effects. And finally, I'll discuss the health benefit. This is the core area of this lecture. I will not discuss anything about animal studies or like laboratory studies, but mainly I will discuss the highest level of evidence when it is available with the meta-analysis and systematic review. If it is not available, I will discuss about the intervention studies. And these are the main area I'm going to discuss about the CNS and skin and dental and cardiovascular diseases. When you look at this chemistry or like a molecular structure of the coconut oil, it has several types of amino acid, but there are a few unique things. Now, if you look at here, you can see there are C8 and C10. Those are considered as a medium chain saturated fatty acid. And then C12, that is a lauric acid. That's the most common part of the coconut oil. Consists nearly 50% of the total composition. And these three fatty acids considered as a medium chain saturated fatty acid. However, other is a long saturated fatty acid, and where this linolenic acid actually considered as an essential fatty acid is quite low also. So there are three things I can highlight here. There are some medium chain saturated fatty acid and predominantly lauric acid, and essential fatty acid level also very low compared to most of other edible oil. Nowadays, there are different type of coconut oil also. The traditional method was considered as a copra oil, which is extract from the copra or dried kernel by mechanical milling. Still, it is happening in Sri Lanka, probably south part of the India. But the most common coconut oil, what we can see the market is, we call RBD coconut oil, is a type of coconut oil that is refined and bleached and deodorized. So that's a common commercialized method. In addition, the virgin coconut oil also considered as a purest kind of coconut oil, which is from the fresh kernel without high heat or chemical treatment. There are a few other types also, but these are the common type of coconut oil, but we can see the market and widely consumed all over the world. However, if you check the composition of the different variety of coconut oil, there's no significant difference. If you go for the composition of this medium chain saturated fatty acids, it's same. And if you take a lauric acid, that's the most abundant for the all three type of coconut oil. And linolenic acid, the essential fat is always less. So there's no significant difference. And if you compare to different type of oil, like a soya or sunflower, there's a huge difference compared to coconut oil. But all these type of coconut oil have a more or less same composition. So some scientists believe actually it's not the composition of the coconut oil, actually it's a polyphonic component. But again, it's more or less same. So there's actually a total polyphonic component different in different types. But still, the amount of antioxidants and everything is not a significant difference compared to some other oil, which I'm not going to discuss here. So, how this coconut oil should be superior, could be like a superfood, or could be detrimental for our health? It is believed it's mainly due to the structure of the fatty acid, which is mainly medium chain saturated fatty acid. and which can produce ketones and which can cross the blood-brain barrier, and ketone can reduce appetite. So it may be good for the weight loss, and probably, and this medium-chain saturated fatty acid has a less calories compared to long-chain saturated fatty acid. So that also could be the one reason. And other reasons, actually, polyphenolic component. However, these are not considered as antioxidants or anything by the FDA because it's widely accepted. But coconut have a significant amount of polyphenols, and it really depends on the type of the coconut oil. In addition, like any other oil, there are some antioxidants as well as this coconut have some anti-inflammatory response. Of course, there are other type of lipids like phospholipids, vitamin E, sterols. However, amount of these phospholipids and vitamin E and sterols are relatively less in coconut compared to other type of plant oils. Let's move on for the clinical evidence. Probably that's more important for this audience. And then starting from the brain or central nervous system. It is believed this coconut oil and medium chain triglyceride are good in the prevention treatment of Alzheimer's disease. What is the main mechanism behind that? What they believe actually, this coconut oil of course consists a lot of medium chain saturated fatty acid, and that can bypass the our lymphatic system and reach to the liver, and that produce the ketone bodies. So in the Alzheimer's brain, actually there's a relatively less glucose. So these ketone bodies can be the good substrate. So that's the argument behind giving this coconut oil or medium chain triglyceride for the treatment or prevention or treatment of Alzheimer's disease. However, I would like to challenge it because when I go to the literature, these reviews are not actually systematic reviews or anything. Those are mainly narrative reviews. And there's no evidence to say the coconut oil convert to ketone bodies in a mixed dish. That's the most important thing. Like Professor Jai Henry also mentioned, we don't eat just one food, we eat mixed food. And assume if you eat a coconut chutney with a rice, so there's abundance of the carbohydrate. So I don't think in the fed state, this mechanism will happen. So it's very unlikely, but that's the main argument behind this main health benefit for the brain due to these ketone bodies. But there are no, to my search, I couldn't find any animal studies or anything. This kind of mechanism happened during fed state. Of course, in the fasting state, this could happen. And with the high doses of the medium chain triglyceride, that could happen also. However, there's another review came this year. They analyzed the medium chain triglyceride on the ketosis. Actually, they found the high dose of or supplementation of the medium chain triglyceride actually induced ketosis. When I went through this systematically, I found they have used only 2 studies of the coconut, using coconut oil. Most of other studies, they use a true medium chain triglyceride, which is a C8 and C10, which is quite different in coconut because coconut consists actually less than 10% of the C8 and C10. So medium chain saturated fatty acid, not similar to coconut oil. So this will not happen in the coconut oil. And actually there's an article also, one original article also cited in that paper. It also found cold pressed coconut oil did not improve cognition or behavior of this Alzheimer's disease patient. So it's quite doubtful whether coconut actually improve this cognition behavior, although it's a medium chain saturated fatty acid, which has a very less amount C8 and C10, which is widely investigated, not the C12 or not other type of the oil. If I move for the skin, and I can remember when I was very young, even my mother and grandmother used to apply skin or coconut oil on the skin and the hair, and thinking it's good for our skin and hair. Interestingly, they are actually one of the systematic review shows something very similar, and most of these studies coming from our part of the world and India and Pakistan, mainly from India. And in these studies, they applied coconut oil for the premature infant. And they found quite positive result compared to control group. Those who applied coconut oil have a good result. One is that they lost less water from their body. So they were well hydrated with the coconut oil, as well as it improved their overall growth and skin condition also. And there was a couple of studies, they combined and done the meta-analysis. That's the only meta-analysis in that systematic review and meta-analysis. And it shows those who applied with the coconut oil have a reduced hospital-acquired bloodstream infection. That's very interesting. But we need actually larger studies also because these are very small studies, but still it's interesting. In addition to that, another randomized double-blind control trial shows coconut reduce atopic dermatitis also. And compared to the mineral oil, it has a significant effect of the reducing atopic dermatitis. So probably that's the reason in the ancient medicine, like Ayurveda and other, they applied this coconut oil for the various skin conditions. So this also shows some positive result. So in the summary, coconut probably have a health benefit for the premature infant and someone with the atopic dermatitis when you apply it. When I move for the dental, this is very interesting actually. And this is not happened in Sri Lanka, so that result actually strike myself also. Something called oil pulling. That's when you keep your oil for your mouth for like 10 to 15 minutes, then you throw it away. And actually this systematically shows they combined 4 studies and they found those who done the oil pulling with the coconut oil compared to distilled water or mineral water, and coconut oil group had a significant low bacterial colony count and it reduced the plaque index also. So that's quite interesting. So this is not widely practiced in our part of the world, but I don't know about India. And I know about sesame oil, they use quite widely, but coconut oil also something new for me, but the evidence shows it reduced the bacterial colony count and plaque index, so it improved overall dental hygiene and overall health. When there's oil, we can't forget about cholesterol, we can't forget about then finally heart disease. So this is an area I'm quite interested, and probably for your audience also. And this year we are very lucky. We got 2 systematic meta-analysis, and both came from the Singapore, and the first one published in the Nutritional Review, and the one of the top nutrition journal with the impact factor of nearly 6. Another one, Circulation, is the official journal of American Heart Association. And that study also done from the group of scientists from the Singapore and Harvard. And both found coconut oil have a detrimental effect for the cardiovascular health. In other words, it increased the LDL and total cholesterol level. And they have analyzed high quality studies, low quality studies, and different duration. And I'm not going to discuss. And they shows all these studies, actually, coconut is not very healthy. And why I'm here today, actually, very recently, we did a most comprehensive systematic meta-analysis. Why I'm saying most comprehensive, because previous 2 studies used 16 and 18 research publication respectively. But here we included all missing studies also. Here we included 23 randomized control trial, and we searched major scientific research database, PubMed, Scopus, and Web of Science. We came up to nearly 1,500 articles. Then we screened to the title and abstract. And finally, we limit systematically with 23 relevant articles and meta-analysis for the 20 articles. What we found, coconut oil actually significantly increased total cholesterol, which is quite significant value, like a 15.42. So compared to other type of oil, coconut oil increases the total cholesterol as well as LDL cholesterol, which is considered bad cholesterol, also very significantly. And the amount is at 10.14 milligram per deciliter. And however, it increases small amount of HDL cholesterol also significantly, which is a quite positive thing, but that is very small amount, like only 2.661. So considering the effect of the total cost and LDL, improvement of HDL level is not clinically significant. However, there's no impact of the triglyceride level. And finally, what is actually, we could summarize as a main finding of this paper, coconut oil significantly increased total cholesterol, LDL and HDL cholesterol in overall. And we did a subgroup analysis, which is not done in the previous 2 papers. And this paper we are happy to share also, and which is published in the Indian Diabetic Association Journal. So you can see this subgroup analysis, coconut oil increases total cholesterol and LDL cholesterol, HDL cholesterol when compared to other plant oil like palm, corn, palm, soybean, and safflower oil. However, coconut oil is actually increase HDL and LDL compared to butter or animal oil. So that's a good sign. So if someone is using a saturated fat, so coconut oil is the best option compared to animal-based saturated fatty acid. So finally, actually, I think we have to consider coconut oil also as another type of saturated fatty acid. That's quite heartbreaking news for most of Sri Lankan. And when we published this and when we do the press conference, they were not very happy. But that's the truth. We have to display the right truth. And we need a larger study to see whether there's a real effect. But this is a very comprehensive meta-analysis. So at the moment, we can say coconut oil is another saturated fatty acid. So we have to go for WHO guidelines. The consumption should be total consumption of calorie from coconut oil in addition to other saturated fat should be less than 10%. So in my summary of the presentation, coconut oil is rich in saturated fat, but mainly medium chain saturated fat. And most of health benefits may be attributed to its fatty acid composition and other chemicals like polyphenols. There's a modest level of beneficial evidence for the skin conditions and dental condition, but the effect of the brain is doubtful, which is very important nowadays, but there's no strong evidence on that. There's no rationale behind that also, to my opinion. And it's very clear, coconut oil increases total cholesterol, LDL and HDL. So it's not probably not a healthy source for the cooking and other dietary practices. Thank you very much for your attention. And if there are questions, I'm happy to take also.
That is wonderful, Dr. Renal. Question is in everybody's mind is whether we can use a little bit of coconut oil, for eating, maybe once in a while, once or twice a week. Will it still increase LDL level? Because we know that between HDL and LDL, LDL is more important for atherosclerosis. So we are only concerned about LDL. So is that permissible twice a week, once or twice a week?
Actually, sir, you can consume small amount. And in Sri Lankan, what we encourage, because we get a coconut oil from coconut milk anyway. So we have another source of coconut oil from the coconut milk. So for the oil purpose, we suggest use other unsaturated fat oil, such as a soya oil or canola oil or something else. And a good thing in the coconut oil, since it's saturated fatty acid, it will not convert trans fatty acids. So some poor families, the coconut they reuse. So that kind of situation, coconut oil can be used compared to some unsaturated fatty acid. But there's again doubt whether that causes it is carcinogenic or something. But it never converts trans fatty acid.
Thank you, Renal. Ritesh, please go ahead.
Yeah, thank you, Dr. Renal. That was a very beautifully presented on coconut oil, and I think we are all wiser, much clearer on the role of coconut oil, as your extensive meta-analysis has pointed out. So thank you for being a part of the symposium. Thank you. So we move on to the next session, and I'd like to invite Dr. Alka Jha, who's a senior consultant at Fortis CDOC Hospital at Vasant Kunj, New Delhi, and she will be elaborating on role of nutritional supplements in management of diabetes. So welcome, Dr. Alka.
Good afternoon, everyone. I'll be talking today about the role of nutritional supplements in the management of diabetes. As all of us, we are very well aware of the rising prevalence of type 2 diabetes globally as well as in India. And it is involving the people with all age group and all socioeconomic strata. There are multiple risk factors for this search, and out of which diet is the most important and most modifiable risk factors in diabetes. If you look at the Indian diet scenario, as per this survey, about 80% of the Indians they have some kind of protein deficiency. The diet, Indian diet, that drives almost two-thirds of the carbohydrates from the refined sources. And as per the IDA, the fiber intake of the Indian diet is very low, ranging from 8 to 15%, which is different from what is recommended by the guidelines. Another aspect is the control of the HbA1c control or the glycemic control in our diabetic patients. Only about 69% of the Indian diabetics they have uncontrolled diabetes as per the ICMR Indian diabetic study, despite of the availability of good drugs and the insulin modalities and delivery options. The goal of nutritional therapy includes to promote and support the healthful eating pattern, emphasizing variety of nutrient-dense foods in an appropriate proportion size. To improve overall health, achieving and maintaining a good weight targets, glycemic targets, blood pressure targets, lipid goals, and if possible to delay and prevent the complications of diabetes. Along with this, to address the individual nutrition need based on the personal and the cultural preferences, and to provide them a tool for developing a healthy eating patterns rather than focusing on a individual macronutrients or the micronutrients or the single food. If you look at the guidelines for the carbohydrate, about 55 to 60% of the energy should come from the carbohydrate. Primarily, they should be in a complex in nature, and the carbohydrates which are high in fiber should be preferred. Substitute the low glycemic load foods for the high glycemic for improvement in the glycemic control. Carbohydrate monitoring is very important, which can be done by carbohydrate counting. Addition of a non-nutritive sweeteners to the diet to elicit a sweet sensations also helps in improving the blood glucose. If you look at the guidelines for the fiber, the people with the diabetes, they should at least consume the amount of fibers and the whole grains which are recommended for the general populations, that is around 40 grams a day. And the rich sources of the high fiber contained carbohydrates are the legumes, whole grains, bread, cereals, whole fruits and vegetables, and they should include as a part of a daily carbohydrate intake. If you look at the types of fat and their contributions, the saturated fat should provide less than 10% of energy and less than 7% in those patients who have abnormal lipid parameters. The polyunsaturated fatty acid should provide at least 10% of energy, in which N6 PUFA should contribute by the 3 to 7% and N3 by more than 1% of energy. If you look at the monounsaturated fatty acid, they should provide at least 10 to 50% of the energy content. Regarding trans fat, it should be less than 1% or it should be avoided if possible. One should be very much clear about the concept of the glycemic index and the ranking of the food items. Those food items which are low or moderate in their GI ranking are preferred, and the food items with a low glucose load of less than 10% are preferred in management of diabetes. We heard yesterday a lot of about the impact of postprandial glycemic excursion, the glycemic variability on the risk of cardiovascular diseases and the cardiovascular risk factors. If we see this communication, which was pertaining to the rule of two-thirds in Indian diabetic epidemiology, which says that two-thirds of the dysglycemia patient, they have a pre-diabetes, of which two-thirds progresses to diabetes. Only two-thirds patient about two-thirds of the patients, they are not able to control their HbA1c on targets. Two-thirds of diabetic patients, they have associated diabetes, hypertension and dyslipidemia, and only 2-3% of the patient, they are able to adhere to the diet therapy. So there is a need for a kind of a food supplement which is low in glycemic index, which can provide a good glycemic control, a good weight control, and also can help a person to improving the adherence to the diet. So what are actually these diabetic specific formula means? Basically, they are the formulas which contains a defined nutrient compositions designed to enable a better glycemic controls. If we look at the nutrients, they primarily includes the high protein, high quality proteins like soya proteins, milk proteins, high fiber content, complex carbohydrate, along with richness of MUFAs, the antioxidants and the micronutrients in terms of vitamins and various minerals. As per the AD Association, these diabetic supplementations they play an integral component of in the role in diabetic management. They improve the health through the healthy food choices. They helps in attaining and maintaining the optimum metabolic outcomes, and they also do prevent and treat the chronic complications of diabetes. This was the study done to assess the effectiveness of these nutritional supplements in terms of their glycemic index, their glycemic response, and the level of satiety in Indian adults. 15 patients were taken, and the participant underwent a 3 days of reference food testing and 1 day testing for the 1 day for the test meal. And as we can see, the flattening of the glycemic the curves for the glycemic index and the glycemic response in terms for the high protein high fiber nutritional supplements as compared to the reference food, which was the glucose. If we look at this subjective satiety parameters, which was measured by the visual analog scale, the study showed that these supplements, they could provide a satiety up to 3 hours in about two-thirds of the study subjects. If we see the evidence for the use of these specific diabetic specific formulas in weight loss, this was a randomized controlled trial in type 2 diabetic patients in which one cohort received the low calorie meal, diabetic specific meal replacement along with the physical activity, and they were compared with the control. And we can see the percentage of the weight reduction. There was statistically significant reduction was noticed in the group which received these meal supplements as compared to the other, and this reduction in the weight reduction was consistent at multiple points of time. If you look at the reduction in the HbA1c, this was again more in the patients who received the diabetic specific meal replacement as compared to the control at 6 and 9 months. If we talk about the control, glucose control in a hospitalized patient is always remains a matter of concern. The patient usually experience high sugars, low sugars, or a lot of variations in the glycemic control, and this is the time when the patients actually require a good nutritional support. So, these diabetic specific formulas, they have a role in this scenario? So, this was the meta-analysis which was done, which includes around 223 studies which study the role of diabetic specific populations versus formulas versus the standard formulas in type 2 diabetic patients. And the study showed that there was a greater reduction in the postprandial glucose, the peak glucose, and the glucose area under curve in patients who received the diabetic specific formulas as compared to the standard formulas. The reduction in the insulin use was more in the diabetic specific formulas, and the incidences of hypoglycemias were also less in the patients who received these diabetic specific formulas. So in short, we can say that there are clinical evidences which supports the use of these diabetic specific formula. They help in improving the blood glucose levels, reduces the hypoglycemia, they reduces the insulin requirements, they help in reducing the glycemic variability, and reduces the length of stay and ultimately the cost benefit. Another aspect of diabetes with the uncontrolled sugars may impairs the immunity. We know that hyperglycemia, they alter the functionality of neutrophils. They affects the complement activation system and affects the endothelial functions by altering the nitric oxide signaling pathways. Thereby, these patients which have who have uncontrolled diabetes, they are at a higher risk of developing infections and at a risk of worse prognosis. As we can see in the current scenario of COVID-19, our diabetic patients, they do face a higher chances of serious complications of COVID-19, and they are at a higher risk of mortality as compared to the non-diabetic patients. So let's see, is there any role of nutrition in this with this respect to the immunity? There are many nutrients which are play important role in supporting the immune system, which includes various proteins, vitamins, and minerals. If we look at the role of proteins, they activate, they help in activation of the T lymphocyte, B lymphocytes, natural killer cells, and therefore good high quality proteins are usually recommended in patients with poor immune system. If you look at the vitamin C, they help in promoting the collagen synthesis and thus supporting the integrity of the epithelial cells. They help in increasing the serum complement level, and they also increases the levels of antibodies. There are researches which shows that vitamin D deficiency is a risk factor for respiratory tract infections and the development of acute respiratory syndrome. And we know that ARDS is the main cause of death in the COVID-19 patients. So therefore, if we look at the immunity aspect, the vitamin D act as an immunomodulator, and they have a role in both the innate and the adaptive immunity. So therefore, we should supplement our diabetic patients with the vitamin D, especially. Regarding vitamin A, it also have a role in innate as well as the adaptive immunity. It helps in maintaining the structural and the functional integrity of the mucosal cells, and regarding vitamin E, which is a fat soluble antioxidant, and they protects the integrity of the cell membrane from the damage of by the free radicals, free oxygen radicals. And we know any kind of stressful condition can increases these free radical productions. The vitamin E enhances the interleukin 2 productions and NK cell cytotoxic activity. Therefore, these kinds of vitamins should be supplemented in our patients. If we talk about the B6 and B12, both have a very primary role in the immunity. In fact, B12 vitamins is the one which requires special attention in our diabetic populations, especially those who are on metformin or in elderly age group, or those who are taking a vegan diet, or using some kind of weight losing medications like orlistat, or have underwent some GI surgeries. These are the categories where the possibility of B12 deficiencies are more. So in our diabetic patient, we should supplement this vitamin. We should supplement with this vitamin. Regarding the role of minerals in the immunity.
Sorry to interrupt, Dr.
It's just a
Alka. Yeah. Could you finish in 2 minutes, please?
Yeah, sure, sir. Regarding zinc, they also help. Apart from the role in immunity, there are studies which shows that they have a role in improving the insulin sensitivity and improving the blood glucose levels. Iron and copper, they do both have a role in the immunity. So in this time of COVID-19, there is a need of balanced diet, and this is a paper published from by our Professor Mishra, which very well highlighted this same aspect. And they suggest the intake of high quality proteins in patients with mild or in patients who are suffering for the COVID-19, and they also supports the use of the micronutrients and vitamins, because they do modulate the inflammatory cascades, and they have a strong antioxidant property. So here I'll stop my talk, and thank you for the patientful listening.
Thank you, Dr. Alka, for that very informative lecture. There is one question. So a lot of people these days are talking about probiotics. So all kinds of diets are there which people are taking more probiotics. Is there any scientific rationale to take probiotic supplements?
If you look at the research, there are some evidences. There are mixed data. Some evidences shows that taking of a probiotic, they help in improving the fasting glucose, fasting plasma glucose, and HbA1c. However, the other they are opposite directions.
So there are some immunomodulatory effects also. So maybe probiotics are good for immunity, Ritesh, but definitive trials are not there. I mean, these days, even a little bit of support and we take it. So that is what it is. I think it will do no harm, and if at all, there may be some good.
Right. So thank you, Dr. Alka. we move on to the last section. Before that, I must announce that we'll be announcing the results of today's quiz after this session, after the last session. And for the last session, which is last but not least, it is extremely important session, and I invite Dr. Manas Barua, who is a consultant endocrinologist from Guwahati, Assam, and he'll be talking on GLP-1 agonists and heart insights from the ReWind trial. Welcome, Dr. Barua.
Thank you very much. Thank you, Dr. Gupta, and thank you very much, Professor Mishra, for giving me this opportunity. Today, I'll be talking on GLP-1 agonist and the heart. I'll give you some insight from the ReWind trial, which was published recently. Before going into the core topic, I want to give you a historical, outline of the important events in the discovery of glucagon-like peptide therapeutics, GLP-1 receptor analog therapeutics. So initially that came with the cloning of the pro-glucagon gene, which has got three major parts: the GLP-1, GLP-2, and the glucagon molecule proper. And later on, they discovered that GLP-1 has got insulinotropic action. It can secrete insulin through the GLP-1 receptor in the beta cells, which is again it's dependent on the glucose level, because the secretion happens only when the blood glucose is high, but it stops when the blood glucose is normal or below normal, so it doesn't cause hypoglycemia. Then in the therapeutic front, we had the first GLP-1 receptor agonist coming in the starting of this millennium, first decade, with exenatide by twice a day injection, short-acting GLP-1 receptor analog, which was followed by lixisenatide and a very popular liraglutide. And finally, we had, at least in India, we had the once-weekly dulaglutide. Of course, the journey is on, and we now have another once-weekly GLP-1 receptor analog from Novo Nordisk, that is semaglutide. And we, in fact, right now we have the first oral GLP-1 receptor analog in the form of oral semaglutide. Just to give you a brief review of why is GLP-1 based therapy so popular, and how is it and how it's evolved actually. Basically, to start with, we had a short-acting drugs, and which was a bit difficult for use, because you have to use 2 injections, and the impact on fasting plasma glucose was not significant. Later on, when we started having the longer-acting drugs, like liraglutide having a half-life of 13 hours, and still more longer-acting drugs like dulaglutide and extended release Byetta or exenatide, we found that the impact on both fasting and postprandial glucose is better. Impact on weight reduction is also better, and there are a lot of other metabolic effects and pleiotropic effects. So we are seeing new research coming up in this area, and new useful facts are coming out and being published in the scientific literature, which is opening new vistas for treatment in the treatment of diabetes mellitus. Now, again, another important point to remember is what are the metabolic defects and what are the roles of incretin therapeutics in type 2 diabetes mellitus. One very interesting fact is that if you ingest glucose orally and if you inject glucose intravenously, the impact on insulin secretion and glucose control is better with orally ingested glucose. And from this discovery, then later on the scientists found that there is something which actually stimulates the beta cell and something in the GI tract, and that group of hormones which actually stimulates the beta cells are incretin hormones, and they're stimulated by the presence of food in the stomach from the distal part of intestines. To cut the long story short, in type 2 diabetes mellitus, this incretin effect is blunted, and that's why the incretin therapeutics are actually complementary to the overall defects which we see in type 2 diabetes mellitus, and which cannot be tackled only by drugs like sulfonylurea or insulin. So it has got a complementary effect, and they are beyond the beta cells. They have got a lot of other effects, of which I am going to highlight today, because I am going to actually highlight on at least on the cardiovascular benefit of this group of drugs. I will not deal with the mechanism of action. Basically, it's to secrete, primarily to secrete insulin from the beta cell in a glucose-dependent manner, and also to suppress glucagon secretion from the alpha cells. But interestingly, the suppression of glucagon happens only when there is hyperglycemia. And when there is hypoglycemia, the action of GLP-1 on glucagon suppression is blunted. That's why the normal or physiological response to a hypoglycemic state is not blunted. So that's why it is a very safe drug in patients who are prone to hypoglycemia. What are the benefits of GLP-1 receptor analog as of now in 2020 with all the good GLP-1 receptor analogs we have now? They are very highly efficacious. The HbA1c reduction is to the tune of just more than 1%. They are cardioprotective, proven by various trials on liraglutide, dulaglutide, semaglutide, and also albiglutide. There are proposed renal benefits, which has been shown in liraglutide and also by semaglutide. Very low risk of hypoglycemia, which I have already explained, and very significant weight loss, even is better than SGLT2 inhibitors. And there, for almost all the preparations do not require too much of titrations like sulfonylurea drugs or insulin. So you just keep on, when you attain a steady state level, you can stick to the same dose for long period, and which is very much patient friendly. And now we have the oral options with the coming of oral semaglutide. The limitations are by and large GI side effects, which are in the form of the nausea, vomiting, diarrhea. But of course, these side effects disappear once you keep on using the drugs for many weeks, like 6, 7 weeks, 8 weeks on, then this kind of side effects are usually decreased. And for some of the GLP-1 receptor analogs, there is a titration protocol where you start with a low dose and over the weeks you increase it gradually so that the side effects are minimal. One black box warning, which is about the thyroid C cell tumor, which is of course not seen in human till now. It hasn't been seen. It has been seen in animal models, but we have to be vigilant. And there is a question mark regarding acute pancreatitic risk, but which has not been proven by large CBOTs so far. So it remains a potential risk, but clinically whether it is very significant or not, that's a question to be answered by clinicians who have been using it for a long time, for many years. Now, this is the structures, the basic structures of different GLP-1. The first ones like exenatides, which are derived from the saliva Gila monostra, which is basically the entire chain of GLP is replaced by certain amino acids to make it resistant to the digestion by DPP4 enzyme, which can digest the GLP-1 receptor and make it ineffective. The another group is addition of albumin side chain like liraglutide and semaglutide, and still another group like dulaglutide and albiglutide using a large molecules, making it a large, protein bound. Like in case of dulaglutide, is bound to the immunoglobulin. In case of albiglutide, it's bound to albumin, just making it big, larger. And here is a core molecule is adhered to this immunoglobulin molecule, and it's gradually released from these sites by proteases, and that's why it becomes a very long-acting molecule. If you compare the features of GLP-1 receptor analogs, to cut the long story short, main differences is in the duration of actions. Like Trulicity or dulaglutide it has a very long half-life, and it is very useful as a once weekly dose. Exenatide, the first one to come up, so twice weekly, and liraglutide is once weekly, and we now have semaglutide, which can be given because of the long-acting, long half-life, can be given once a week. One more important point I want to highlight here is that there is a basic difference between the short-acting GLP-1 receptor analogs and the long-acting GLP-1 analogs. It's a short-acting analogs are better for reduction of postprandial hyperglycemia, but long-acting ones are slightly better for controlling fasting hyperglycemia, but they also have a substantial impact on the postprandial hyperglycemia also. So for controlling global hyperglycemia and to get a better HbA1c reduction, obviously you need to use longer acting ones, and that's why they are becoming more and more popular. So all these molecules come with excellent devices, and as of now, dulaglutide has the advantage. It has got a once weekly injection. The entire dose is there. Patient doesn't have to dial the dose, just have to inject and then discard the pen. So that way it becomes a better device for uses for your patients. So what about the efficacy overview? I think clinicians are going to be interested in this slide because this compares, not necessarily from the same trial, of course, that compares the efficacy of different GLP-1 receptor. Let's talk about the two main GLP-1 receptor analogs which are available in India. So if you look at the efficacy for the dulaglutide in terms of HbA1c reduction compared to liraglutide 1.8 milligram and dulaglutide 1.5 milligram, this is the full maximal approved dose. There is non-inferiority. That means they are comparable in terms of HbA1c reduction. Of course, amongst all the GLP-1 receptor analogs, semaglutide has shown that it has got the best impact on the HbA1c reduction. And similarly, as because both liraglutide and dulaglutide are long-acting drugs, you have significant reduction of fasting plasma glucose compared to exenatide BID, which is a short-acting drug. It doesn't have much impact on the fasting plasma glucose. But if you compare only dulaglutide versus liraglutide, you have the similar fasting plasma glucose reduction. This is a non-significant difference, so it is available from the clinical trial evidence. In fact, this is a head-to-head trial in a single trial performed by Eli Lilly. So what about a weight reduction? Here again, the best would be probably semaglutide, and second one probably would be liraglutide, and then only dulaglutide. So liraglutide has been found to be superior to dulaglutide in reduction of weight, body weight, and semaglutide has been found to be the most superior amongst the GLP-1 receptor analogs in terms of body weight reduction. And for the common adverse side effects, I don't think there is much to talk about because it's mostly similar, but only one important clinically relevant point which I want to mention is that shorter acting drugs has a slightly more incidence of vomiting or nausea, but longer actings are almost similar if you do a head-to-head comparison. So there are significant similarities amongst the different classes, but there are significant differences. But for the long-acting ones, as of now, for liraglutide and dulaglutide, we have for the efficacy part, we have similar reduction in HbA1c and fasting plasma glucose. So glycemic efficacy almost similar, but metabolic efficacy is slightly better at liraglutide because it gives you better weight reduction. So now, the main point which I want to discuss here is the cardiovascular outcomes with these trials. And we know that cardiovascular disease is a very significant comorbidity, which is a cause of death as well as different morbidities in diabetic patient, be it non-fatal MI or fatal MI or fatal stroke or non-fatal stroke. So recent guidelines from American Association, American Diabetic Association and other different international agencies says that if you have atherosclerotic vascular disease predominance in your diabetic patients, then probably this group of drugs should be considered at the very beginning. And if the patient has got a heart failure kind of presentation, then probably SGLT2 inhibitors with proven safety and efficacy should be used. But of course, this usage of this group of drug is limited, at least in our country, by the prohibitive cost. And that is something with all the clinicians in our country we are fighting for, actually. But then as of now, there are selective patients where the cost-effective ratio of getting a more benefit out of it by preventing a future cardiovascular event, if it is more important, if you look at the long-term cost effectiveness, probably these drugs are still, they have got place in our country also, and that fact cannot be ignored because we do not exactly look at the long-term benefit of preventing major life events in diabetic patients. We just look at the current scenario of controlling hyperglycemia and probably to avoiding hypoglycemia. But we have to look beyond that. We have to look at the future safety, longevity, and disease-free interval of a person in his lifetime. And to that end, probably these drugs are going to be very useful. And this is a story of the different CBOTs conducted with different molecules. So of late, we had the Rewind trial, Pioneer trial with semaglutide. And as of now, in fact, the oral semaglutide is being tried in the SOUL project, which is also happening in India. I'll just give you an overview of the different trials, which there are some basic differences. So I want to highlight here. Rewind trial had a significant numbers of patients without established cardiovascular disease. So they had a primary prevention cohort, which was not seen in the case of Alexa or Harmony trial, where entire population was already having established cardiovascular event. So that's how it is different. So prior CVD was less in case of Rewind. They had huge, almost all of them had huge number of inclusion of subjects. So very powerful studies. Another important point I want to highlight here is that Rewind trial with dulaglutide included patients with a very low HbA1c. So to see a significant difference in cardiovascular event with a very low HbA1c, so that you can nullify the impact of hyperglycemia, it's a bit challenging task. And I think we should compliment the sponsors for taking up this challenging task, because you don't expect many events to come up in the entire duration of the study. Median follow-up of Rewind trial also was much more, obviously, because your expectation is less number of events, so you need to follow up your patients for longer period. So that's how there is a basic difference in design of the study compared to the other studies. And if you look at this, this is a very interesting slide. This actually gives you the number of events per 100 patient years for all the placebo group patients. They're not the investigational drug group patients. I mean, they are treated neutrally only with a conventional therapy without adding an active comparator. So here you can see that it's about 4 to 7 for all the trials, but for till the Rewind trial was designed, then the rightmost corner you can see that the events for even in the placebo group, the events were very less. So you can expect that the inclusion, the type of patients which you are including in your studying is very important in deciding what kind of events you're expecting. So Rewind didn't expect many events to happen, and that's why even smaller differences amongst between the studied group and the placebo group also becomes very significant. That's why you may not see a very big, huge numerical difference between the placebo group and a dulaglutide group in the final analysis of Rewind trial. But even that becomes significant because your patient cohort was significantly different from the other trials which are already published. But coming to the result of dulaglutide, Rewind trial with dulaglutide, the 3-point MACE, that's cardiovascular death, non-fatal MI, and non-fatal stroke, the composite cardiovascular outcome was significantly different. There was a statistically significant difference of with a p-value of 0.26. So hazard ratio was 0.88. But if you look at the individual component like cardiovascular death, which was different in leader trial, non-fatal mitral infarction, which was significantly different in Harmony trial, they were not different individually. It is obvious because you had only 30% of patients who had a prior CVD. So you cannot expect huge difference in the individual component. But it's a standard protocol to look at the 3-point MACE only when considering the superiority of a molecule. And to that end, to that end, liraglutide definitely showed superiority over placebo. So in summary, dulaglutide in Rewind successfully made the primary endpoint in significant reduction of cardiovascular death, MI, and stroke, the 3-point MACE. And there was insignificant but numerical reduction in cardiovascular death, non-fatal MI, and non-fatal stroke if you look at an individual component. There was no signal for increased heart failure hospitalization, and composite renal outcome was also, there was significant reduction. And that is something very interesting we have been seeing in all the clinical trials like liraglutide, semaglutide, and even dulaglutide. So it has opened new vistas as regards to diabetic chronic kidney disease. Maybe these drugs are going to be beneficial in retarding the progression of diabetic chronic kidney disease. So in conclusion, with regard to the Rewind trial, dulaglutide is superior to placebo in a reduction of composite cardiovascular events as in middle-aged and older people with type 2 diabetes mellitus with previous cardiovascular disease and cardiovascular risk factors. So this is a summary of different trials. Probably the time will not permit me to go to this, but again, you can see that there is these trials with red fonts. You can see that there is significant reduction. The confidence interval is lying on the left side of the line of unity with a p-value which is statistically significant. So that is for leader, sustain, Harmony, Rewind. Of course, Pioneer was not expected to show that kind of result because they did it for a shorter period. This is the cardiovascular outcome trials comparing GLP-1 receptor agonist and placebo, you can see that the trials which I have already mentioned, they are falling on the left side of the line of unity for the missed endpoint. And for if you just compare similar molecules from the same similar class DP4 inhibitors, they are non-inferior because you can see that they are falling on both sides of the line of unity. So SGLT2 inhibitors, we know that canagliflozin and empagliflozin has shown a superiority, but dapagliflozin hasn't shown the superiority. It is neutral. So when you talk about using this molecule, probably the patient factors would come. First of all, of course, it's not mentioned here is a cost. Cost has to be considered. But again, I want to remind my audience here today that we have to look at a long-term benefit while choosing a molecule, not the immediate cost. And you have to probably spend some time with the patient in discussing the long-term benefit of this molecule of preventing that single cardiovascular event or that single renal progression in a single patient, which might be very costly affair for the family, for the patient, and for the society also. Device is very important. As I said, all the devices are quite good, and dulaglutide as of now has the best device. Probably if patient doesn't even see the needle, patient doesn't have to dial. He just have to he or she just has to inject entire dose in a single point of time. The dosing is very easy because there is no dosing, only in a single dose, same dose can be injected time and time again. So that is another benefit for once weekly dulaglutide. So with this, I complete my presentation, and I'm open to discussion. If there are any questions, I can answer these questions.
Thank you, Dr. Barua. That was very nicely covered. I'm sure there'll be questions, but yeah.
You can take one question if there is any.
Okay, I cannot see any question here. Yeah, yeah. Okay, thank you, Dr. Barua. And now Dr. Amrita is going to announce the results of the quiz which we have today.
Hello, everyone. So the first question on diet, which was the answer was Valine. So the correct answer was given by Seelam Rajita, Dr. Rajita Seelam at the rate of gmail.com, Taranjeet Kaur, taranjeet.kaur@atwichealth.in, Dr. Brij Bajaj, at the rate of gmail.com. Second question was on hyperglycemia, and correct answer was given, fastest correct answer was given by Dr. Shakti Swaroop Mishra, Dr. Shakti 2007 at the rate of gmail.com, Sonal Chaudhary, sonal.eatwise at the rate of gmail.com, and Dr. Vikas Jaiswal. And the third question, which was related to COVID, so the fastest answer were given by Rekha T, rex.arunkumar at Megha Mukhija, mmhealthmania at gmail.com, and Mamta Parnami, Mamta Harsh 1974 at gmail.com. So please expect email from our side in a day or two and with your gifts. Thank you so much for the participation.
Okay, we have come to the end of this very, very successful program. Since yesterday, we had a total of more than 900 logins. And that's wonderful. And these logins are not only from North India, but South India and neighboring countries too. And the success of program behind that is my team. Organizers, Dr. Ritesh Gupta, Dr. Amrita Ghosh, and my colleagues, Atul, and my whole team, Alka, and the rest of the team, Mr. Huck's team, Kanika, Koel, everybody, Prakash. But I will let Amrita name them properly. But I'm very indebted to everybody because they have spent a lot of time in the last couple of days in organizing this conference and making it so successful. I am also thankful to all the pharmaceutical company. I visited their stalls there. Some of the stalls are very good. So I'll ask now Dr. Amrita to give a vote of thanks.
I thank you all wholeheartedly for your participation. All 900 plus logins have meant a lot for us. This was a lot of encouragement for us, and we hope to see you all in the next edition. From my team, I would like to thank Koyal, Kanika, Mr. Haq, Irshad, Shamshad, Prakash, and all others who have been there with us. And I would like to thank my mentor, Dr. Ritesh Gupta and Dr. Anup Mishra for this, and all the pharmaceutical companies who have been a part of this and made this a huge success. I thank you all. Thank you so much.
Before we log off, a final reminder that any of you who have logged in today, they want free copy of the book, Diabetes with Delight, which I have written. Please email uh, Koyal Datta, KOELDUTTAC @gmail.com, and we'll send you by courier the free copy. So with that, I thank once again my colleague for making it such a stupendous, excellent success, uh, uh, a very big success for, since we launched this program, we have logged in the highest number of people, and so each one have done remarkably well as far as their contribution is concerned. I thank them once again. So with that, I log off, we all log off, and have a nice weekend. Thank you.
Thank you.
you.